Okay.
Mm.
Sitting here with Blake Withers, and someone, one of my friends sent me your page and said I need to be paying attention to what you have. So I did that. And then for me, I think I just got enough questions on peroneals and tib post, and I have nowhere to send people. And I was like, you want to come on and do a podcast? So yeah, tell everyone who you are.
Yeah, mate, thanks for that's nice. Someone sent you the page. I was thinking, because I listened to your podcast and I really enjoy it. But I wanted to ask, am I the first podiatrist you've had on? I don't think you've had podiatrists on before, have you? Have you had one on?
I don't think so. And I probably, me personally, my experience has like not been that good. So I kind of like, probably
Yeah,
don't like,
yeah.
I don't know if you could speak to it, but I'm like, I probably wouldn't get along with most of them. So yeah, I don't think I've had one on. No.
Yeah, very exciting.
I mean,
Well, yeah,
it's kind
that's
of like a Band-Aid, isn't it? The way, if you just look at it from outside, like me, it's like a podiatrist. I'm
for
thinking
sure.
like, you're just going to put an insert in my shoe, or like, isn't there a way that we
Yeah,
could train them and strengthen them, or, and
yeah,
so to speak with one who can see both sides, that's what I
yeah.
would be looking for. And I think you're there.
Yeah, well, I guess podiatry, because it's so different between like over in the States, podiatrists can do surgery and it really is, we call it like the kinematic model of care. And even me as a musculoskeletal podiatrist, Australia and the UK are very similar. It's come from this idea of we're trained in biomechanics and biomechanics kind of forms the basis of our thinking. And there's some other things that we're trained in, wound care, dermatological care, but we're trained in this kinematic model of the really older model of you have a foot, the foot rolls in, this is bad, this is faulty mechanics, we need to correct that with an insert. And once we correct that, you're going to be okay. And the cause of all your pain was from that. Now, that's a very oversimplified version. And some people certainly still treat that way. But the problem with that was, even if you do treat that way and believe that, it still helps people. If you have a foot that rolls in and I put something under the inside and I correct it, I'm correcting it, I think, and you're getting that improvement. But it's coming from because I'm unloading the tib post, and we can really get into the biomechanics of it. So it works for you. So like, great, obviously what I'm doing is helping. And now it's evolved into what I do now and what I call myself as a musculoskeletal podiatrist here in Australia, where we do foot orthoses and we do inserts and we're trained in biomechanics and we really understand footwear. But we, just like anyone else, just like my partner who's a physio, like our physiotherapy colleagues, we understand rehab and running programming and loading and tendon principles and bone principles. And that's relatively new. It's growing and there's more podiatrists that are becoming more proficient in rehab. So although I don't like to say it like this because I like for us to be seen as a different profession, I treat exactly like a physiotherapist, and I treat very, very similar to yourself, using loading principles, gradual progression, understanding the person, communication, all that type of thing. But I like to jokingly say I can do some of the fun stuff, and I just call it arts and crafts. I get to play around with foot orthoses and footwear and really dramatically unload these tendons. Now, the Achilles is a bit different because it inserts onto the calcaneus, but the tib post on the inside, the peroneal on the outside, I can dramatically unload those tendons every step that you take with a simple insert while we're getting you strong. And the majority of people come out of them in the long term. So I do that 3 days a week. I work about probably see about 30, 35 patients, and it's purely just below the knee. So anyone that comes in to see me, it's an Achilles tendon, it's shin splints, it's tib post, it's forefoot pain, it's heel pain. And I've just been seeing that. So I was saying to you off air, for an average day or an average week, I might see 20 Achilles tendinopathies or 20 tibialis posterior or peroneals, all in different cohorts, from the 70-year-old guy who wants to get back in the gym, the 55-year-old postmenopausal, female that's just started HRT where there's some hormonal things going on with their tendon, or the 20-year-old elite runner, or the young kid that just wants to play on the beach. So I get to see it in all these different contexts, and I'm lucky enough to work alongside 4 sports physicians. So they're like an orthopedic surgeon in a specialty, but in sports medicine. So I get to work alongside them. So I get to utilize them, and speak with them, which is great. So, they're more the medical workups. So that gives me a nice, unique perspective. Doing my PhD in running related injuries, and my favorite cohort to work with is runners. I run myself. Running injuries are so common, and people just get unfortunately some crappy advice of just either rest or just have an insert. They don't get a running program, they don't get a strength program, and half the people that I see, the reason that they haven't been able to get back to running is just no one's giving them a program. They've got all the right other stuff. I'm like, you just need to do a little bit less and improve over time. I do some podcasting, sports medicine projects, some socials, some YouTube, and yeah, my partner's a physiotherapist in the lower limb. So our whole house is basically just talking about knee pain and Achilles pain. When we're having dinner, we talk about cases at night. So my life is basically wrapped up in musculoskeletal medicine, which is awesome. And I love talking about it. It's really fun.
Why'd you start?
Yeah, good question. I was actually going to do physiotherapy, and then I realized that I'm smarter than that, so I'm going to become a podiatrist. No, I'm only just kidding. I'm only kidding. So I just really like the human body. I just find it so amazing, and I know that you do too. I can tell from your socials. Like, it's just incredible that the human body is like this, and the cells and the changes, and how it can manipulate different loads to cause different changes and different stimuluses. And I originally wanted to do pharmacy, thought about medicine, then thought about physiotherapy. And when podiatry come up, the idea of just being a specialist in one area, I really love. So as soon as I graduated, I'm just seeing below the knee. Now, I can legally, within my scope of practice, to treat some people with knee pain, patellofemoral, and I can screen for hip and knee, but I'll send off to my physio colleagues. I love the idea of just being a specialist in one area because you just get so much exposure. And I jokingly say when I'm researching it, I only have to focus on this area. You ask me about rotator cuff, I know the basics, but I don't have to learn about it. Whereas, doctors and orthopedic surgeons and physiotherapists and chiros, they have to learn about the whole body. Whereas for me, I just get to focus in on the one area. So I love the human body and I love the specialty of it. And podiatry really does that quite well.
So, how do you feel talking about the peroneals tib post? Do you kind of look at them? Because I know basically nothing about these tendons, and I do a lot of
Yeah.
patellar tendon, Achilles, but it's like these two. I'm like, I don't really know. Are they kind of like opposites or no? Because one's on the outside of the foot, one's on the inside. Or how do you look at these two different?
Yeah.
Yeah.
So I guess in the clinic, we treat them very similar to the Achilles. Now, of course, Achilles, it's a bigger, thicker tendon. We look at what load is going to be most provocative for a tendon. We're talking max dorsiflexion, with high magnitude. It's very similar with the tib post and the peroneal because they basically run next to each other. The only difference is the insertion. The Achilles comes down and inserts, and let's just say, for argument's sake, the middle of the foot. So it's not going to do a whole lot of supination and pronation. Muscle contracts, the tendon pulls. Whereas the tib post comes down on the inside. So if you just imagine it, you're pulling on the tendon, you're going to get some plantar flexion with the tib post, but you're also going to get some inversion. So it does have more than just one load that's responsible for. And the same thing for the peroneal. So they are in opposite. The tib post is mainly an inverter and a plantar flexor, whereas the peroneus brevis, which comes down and inserts. I don't know if you'll have video on this, but I always have my foot model on me. Every podiatrist always carries a foot model on them just in case. One inserts onto the peroneus brevis down the base of the fifth, and then the longest wraps around underneath to the base of the big toe. So when we think about those, if you imagine for the Achilles tendon, if we want to deload an Achilles tendon, as you come into mid stance, your foot will hit the ground, your tibia will move over the foot, and you'll have ankle dorsiflexion, which will load the tendon. Now, we know very, very clearly, which I really hope we talk about today, simple heel raises and heel lifts can really unload that compression at the insertion and the tensile force. And even high-pitched shoes can do that as well. With the tib post, it's a little bit different. If it's on the inside, certainly if you had that ankle dorsiflexion, you're going to load the tib post, and the compressive loads are high in the tarsal tunnel. But as that tibia moves forward, what do you get with ankle dorsiflexion? You also get subtalar joint pronation. And the tibialis posterior main insertion is on the navicular tuberosity, which is on the inside of the middle of the foot. So if you think exactly the same loads as the Achilles, where are the high compressive loads going to be? It's going to be on the navicular, on the insertion, because you've got to have that bony part and in through the tarsal tunnel. But where do you get that tensile and that lengthening of the tendon is going to be coincide with maximal ankle dorsiflexion, where you have maximal subtalar joint pronation, which is at the end of mid stance. So why that's so important to understand is when we think of unloading, I haven't given a foot orthotic for an Achilles tendinopathy. I've given like 2, and that was because patients wanted them, because I don't think that controlling or reducing the amount of pronation excursion is going to influence the Achilles that much compared to a heel raise and a high pitch shoe. But if I'm talking about using an insert, or I don't want to say an arch support, but using something that contours the arch, I should be able to apply a supinatory force underneath the inside of the foot. That's going to reduce how far and how quickly I pronate, and that's going to significantly unload the tib post. So that's why we use these inserts, because they can have such an influence. And if we understand the loads, then we can use different materials, we can use different footwear to really unload them. So when someone comes in to see me, I can utilize that to really calm it down. And I don't know how you work through your phases, but I love this 3-phase approach that I tell all my patients is, Phase 1 is the pain phase. We just need to calm it down. The rehab's important, don't get me wrong, but we just need to calm it down. We might use tape, anti-inflammatories, maybe injections, shoes, relative rest, deloading, whatever it may be. Then we move into the capacity phase, and that's where the rehab comes in. You're comfortable to start the loading. We're talking about calf raises, maybe we're talking about some meaningful activity return, maybe it's a return to run program, and then we move to the minimum effective dose. Now, this is the fun part that we have lots of nuanced discussion around is, what do you need in your life to maintain this physical capacity? So for someone, and I'm sure you see patients all the time, they need to maintain their heavy, slow isos or their tendon gets sore. Or for some, they might need to maintain wearing an insert because they have a degenerative part of the tendon, or they might need to maintain, they always wear heel pitches, or they always wear a high pitch shoe because they can't get into a low drop shoe. Now, I'm really passionate about making it about the person. If someone's got, I'll give you an example, I see lots of people with metabolic disease, they've had chronic tendinopathy, and they just want to play a round of golf. How harmful is it for that person to wear a high pitch shoe and a heel lift for all of their golf games? They've done all the rehab, all the right things. Do we need to tell everybody to get out of these things? Because they can certainly try, but maybe they won't. And we weigh up the associated risk. What's the risk of wearing a heel pitch in your shoe for the rest of your life? It's probably pretty low compared to you just trying to get this tendon to recover. And some people don't. And the research tells us it doesn't. Not everyone recovers from tendinopathy. So I want us to kind of bring that into, yes, the rehab's important, but sometimes the unloading is just as important, and sometimes even more important. So that's how I think about those tendons.
Yeah, okay. That phase approach to getting the pain to settle when people come to you.
You like that one?
Yeah, I mean, so it's probably hard to do good rehab if you're always going back and forth out of that thing. Are a lot of people just stuck in that?
Yeah, well, they come to see me, and this is, I guess, as a podiatrist, we talk about inserts and heel raises and all these different, I call them unloading therapies, which, my critique of other health professions is they need to get better. And a part of what I do on social media is trying to teach other health professionals to use them, because you come to see someone, and I'll give you an example of someone that I saw yesterday. This is my last case of the day. Sub-elite triathlete who has had a history of Achilles tendinopathy, has like an ankle equina, so we know that's a risk factor for an Achilles, and had some tibialis posterior pain. Saw the sports doctor sent to me for some run programming. Now, there was a bit of a lag between them seeing me and seeing the doctor, so they'd gotten back to a higher level of running, but they were still getting some discomfort. And getting them out of this pain phase. So he, for his job, which was awesome, he plays basketball with kids 3 hours a day, Monday to Friday, which is really, really fun. He was playing basketball in the Adidas Samba, which is a flat shoe, right? So when he was coming to see me, we're talking about, we need to start some rehab. We need to get this tendon strong and capable. But at the moment, it's too sore. It's too painful. If your current loading is too high, if we add more on with rehab, it's very likely just to flare up, or it's going to bring us backwards. So how do we calm that down when you do so much on your feet? So thinking of that for the tibialis posterior, was it that sore? We didn't need an insert, and if we know the load, what's going to aggravate it the most, it's going to be that ankle dorsiflexion and pronation. So what do? In his flat shoes, which really make the footwork hard, we just pop 2 8mm heel raises, medium density EVA, to lift up his heel. And he's going to wear them every day when he's going to work, because we need to get him out of that pain phase to then start the rehab. And patients always come to see me and say, listen, Blake, I don't want you to put me in an orthotic or a heel raise, or I don't want you to do anything. I just want to start the rehab. Say, well, you're walking around day to day with your job with a 5 out of 10 pain. We can't just add more load and expect you to get better. We just need to calm it down first. And all I want you to think of as these therapies, whether it be shoes, inner soles, taping, heel raises, they're just to calm it down. Most times, you're going to be not needing this in 6 months or 12 months or even 3 months. But at the moment, how else are we going to expect to calm this down? And I don't see this done that well. Like if you're taking 50,000 steps throughout the week, let's say, that's 50,000 opportunities every step, or let's say 25,000 if it's on one side. That's an opportunity for us to unload this painful tendon. So let's say someone's got patellofemoral pain, which I know you see a lot of. How might we help someone with that? We know that knee flexion is going to load the patellofemoral joint. We might get them spending more time barefoot or in their flat shoes, so we get more ankle dorsiflexion and less knee flexion, and then vice versa for the Achilles tendon. So people come to see me and go, what do I do? I'm like, you've got all these things at home. You've got high pitch shoes, wear them more so we can get you to the next phase of this capacity phase. And of course, you go between those phases, but that unloading is just so important. And it's the same for the Achilles tendon. I see people, I'm like, you've already got high pitch shoes, wear them as much as you can because it's going to unload your Achilles every single step. Like that's going to make you feel better. And it's also going to help us get to the point where you can start to do this heavy loading sooner.
Okay, you talked a lot about the tib post. When there's the peroneal tendinopathy, is it similar? You can put a heel wedge in and kind of offload it, or and then is it opposite of like, so with that tib post, it's getting into that pronation that's kind of like causing this stress, right?
Yeah. And that's the most amount of tensile load. So most amount of tendon lengthening with magnitude, because you pronate pretty quickly as your foot hits the ground. You do pronate pretty quickly.
So what is the stress on the peroneals? Is it the opposite?
Yeah, it's so as you go into, because you've got the peroneus brevis, which is the base of the fifth, and the longest comes onto the base of the first ray, which is, you've got your first big toe joint, you come back, you've got the cuneiform and the first met, so that the first ray is on the base of that cuneiform. And that does control a bit of pronation as well, but it is mostly loaded when you come into that ankle dorsiflexion as well. And then when you push off, you have a little bit of like kind of supination. And again, it's variable within the population because, human feet are all very different, but the tib post is mostly the one that's loaded. But then we kind of talk about foot type as well and where that plays into it. So, flat feet and high arches, which are not diagnoses at all. And I hate when people get told that they have this, because you're just describing someone's anatomy. It's like saying, you've got long fingers and I've got short fingers. It doesn't really mean that much, and you can't change it. And we know that you don't need to change it to get better. So if someone has a flatter foot posture, what we can hypothesize is you've got more mobility through your subtalar joint. Well, then when you pronate, you're probably going to pronate further and a little bit quicker. So yes, you load the tib post more, but as you know, what we can't understand with human bodies is we don't know in biomechanics. And I lecture at biomechanics. I mentioned that before. I teach it at university in undergraduate level. We can understand biomechanics really well, and we have a big lab and we can put the markers on the instrumented treadmill, but we can't understand how much it takes until that tendon or that tissue is going to fail. So you can pronate a heck of a lot but not have any pain, and people can pronate a little bit and have pain. So we can't say that this tissue needs this many loading cycles to fail. So what we say is the biomechanics gives us a clue as to where the load comes up. So if I see someone with a flatter foot posture and a more flexible foot, we're probably going to load that tib post a little bit more. And that means when it becomes important is if we're talking around foot orthoses, I might need a different device. So the one you get from the chemist is probably not going to have enough force to oppose that pronatory force. And one that we can make custom made may have enough force. So there are some nuances between what type of devices that we have. And the same for the peroneal as well. You see, a really laterally loading high arch foot type, and you see some people, they walk on the lateral border of their foot and they have a peroneal tendinopathy. It's really hard to unload. So you can use simple wedges, which will help, and footwear, but sometimes you need a device that's custom made to the shape that really comes up and around. And there's all these different material underneath to try and actually basically make them pronate so you can unload that tendon. So they're not, basically supinating and kind of inverting as they roll over.
What's more common? Post tib?
Post tib
how much
for sure.
more common?
I don't know the actual stats because it's not heavily researched. And even if you look to the research, I think we were talking about this offline, you look to the research, there's not a lot on tib post and peroneal. And I work with a lot of people that have them, and we kind of treat them like the Achilles because they're somewhat in the same area, but not really. One thing I think, and I know Ebony Rare put out an awesome study for this. For the Achilles tendon, there's plenty of differential. So I this year I've taught I've probably done maybe 4 conferences, and every conference I've made it an actual, it's got to be a goal to speak about this. And this is a great example to do it on the podcast. For the back of the Achilles tendon, we need to make sure that we have the right diagnosis, because we know these tendons can be sore for a long time, and you do wonder, do we have the wrong diagnosis? So for the Achilles tendon, I usually say the things that you need to work out not going on, is it the peritendon or the parotendon? Is it the plantaris, the sural nerve, and an os trigonum or an accessory bone at the back? Is it the subcutaneous bursa? And this, I think we were talking about this as a post. The subcutaneous bursa sits on the outside of the insertion of the Achilles. So if you push into or you've got pain over the insertion of the Achilles, if you just push into it, you can't tell if it's the insertion or if it's the bursa. You can only tell from a thorough history. So if I feel great in shoes, might be more likely to be the Achilles. But if I'm barefoot, that should load the Achilles more. And people come in and say, Blake, I've had this Achilles for 6 months. I hate wearing shoes. It feels better when I'm barefoot. That doesn't fit the bill of Achilles tendon. And then you look in the back of the shoe and it's probably, they might have a Haglund or a bony protrusion, and the treatment's completely opposite. That doesn't need any rehab. That just needs a cutout in the shoe, some anti-blister pads, some padding around the side, and maybe some anti-inflammatory. So that's really important for the Achilles. You've got to make sure. But then for the tib post and the peroneal, it's a little bit different because you come down into the foot, and we work with a bunch of doctors, and luckily they can order MRI. So a lot of cases that I see have already had an MRI. And I made it a goal of mine the last couple of years. So if I see a patient, they've already had the diagnosis and I'm just delivering the therapy, I've made it a goal I pull up their MRI where their discomfort is and associated symptoms, and then I'm able to assess their foot. And that's really unique. Not everyone has the ability to do that. And what I basically want to see is, if I was to assess this without the MRI, how accurate would I be? Like, would I be close to where their pain is on the scan? And I am surprised time and time again where I'm pushing into their tendon and they're saying it's sore, and then we have a diagnosis on the MRI, the tendon's pristine and it's the joint, or it's the nerve, or it's some surrounding tissue. And I think I would have misdiagnosed this for sure. If I didn't have the MRI here, I already had that workup with the medical doctor. So within the inside, you've just got to make sure the main one to rule out is a navicular bone stress injury, because the insertion on the tib post on that navicular tuberosity, if someone has diffuse midfoot pain or pain around the tib post and pain at night and pain with every step, and they're a runner or they're an active person, you just need to make sure that's not the navicular, because that's a high risk bone stress and the outcomes are horrible if we miss them. And the average diagnosis, Jake, it's 6 to 9 months until that's diagnosed, which is crazy. Just crazy. Back to Saxena paper. So it's the right diagnosis, because if you treat this like a tendon and it's like a peritendon or the sheath, it's going to hate you. It's just going to get stirred up and painful, and people go through this rehab time and time again, and it's just the wrong diagnosis. And it needs maybe it needs a boot. If it's a peritendon in the tib post, maybe sometimes they need a corticosteroid injection, which we know is contraindicated or not recommended, for tendon. So we've got to get the right diagnosis, and that's why you just need to work with someone. I do online consults. You can see your people in your local community. It's worthwhile getting it assessed if you've had some failed attempts, because you might not be dealing with a tendon, or you might be dealing with something else.
You can get the peritendon or paratendon, whatever they take the D out of it when they, I don't know why that is.
I know, it's really weird. It's tenosynovitis. I know everywhere calls it paratendonitis, because one say it's inflamed. But, the key for those is they get worse with more activity and they feel best in the morning, compared to a tendon. And I've seen some that I've tried to manage, and I usually give them about 4 weeks, and I try to calm it down as much as I can, really deload. And I basically treat it like a bone stress, like no loading, complete rest, because you've got that fluid around the tendon. And the theory is when the muscle contracts, the tendon will shorten and all the fluid around the tendon gets compressed and irritated. And so many of them, they get a corticosteroid injection between the tendon and the sheath, and they just completely settle down. It's amazing. Now, I'm not saying that people need to go out and have injections. This is with a medical doctor, but in my previous years, when I first started, I would have held on to that person and tried to rehab them for months and months and months. But now, we really try to settle it down. And I was like, you need to go and see it. This might need more pharmacological management. And then will you come back and see me? And as I was saying before, you're in the pain phase and I just can't seem to get you out of it. So you need to go and use maybe injections or any inflammatories and get you down to there. And that's where it's hard online, because you can't have this nuanced conversation of, you never inject a tendon. Whereas in these nuanced conversations, say, well, sometimes you may, but it's not actually a tendon, it's something different. Or you might have a tendinopathy associated with a peritendon and you can't settle the peritendon down first, so you need to do these things. And that's where those nuanced conversations are just so important. So you just got to have the right diagnosis, and it's hard at times.
That's kind of, I've had that question on the steroids, and I'm like, I think if you inject outside of the tendon, it might be okay, but doing internally is like very, very toxic to the.
And you can strip it. Sometimes you can see, so you have the tendon, the peritendon, and if you have some perineal tissue and it's chronic enough, and sometimes it doesn't have to be corticosteroid, it can just be high volume. And you can actually see it strip. It's really, really cool. I haven't seen it that often, but and I have a great response.
So, okay, this paratendon issue, I had one with the Achilles, or a few people with the Achilles, and kind of just trying to let it settle down. But you can get it with the tib post.
Yeah, it's really common in the tib post, and we don't have a lot of treatment options other than calm it down, because it's not like a loading tissue. There's one study from 1985, and I've asked we've had Ebony Rio and people like that on the podcast, and I've asked everyone about this Hiradoid. Have you heard of the Hiradoid and Voltaren wrap protocol? Have you heard
Yeah,
this for the Achilles?
you actually sent it to me because I
Oh,
posted
yeah.
a case study
Yeah.
of a sprinter who had what I thought it was, and you sent me a couple
Yeah.
slides with like that cream that you can put on at night.
Yeah, so you speak to the medical doctors and they don't recommend it because it is pharmacological. And as podiatrists here in Australia, we are, and I've checked, with our association and with the insurance, we do a pharmacology course. So we can, we can talk about this. And of course, we always recommend speaking with your pharmacy or doctor. So it's using Hiradoid cream mixed with Voltaren. You wrap it over the peritendon and you wrap it in Glad Wrap and you do it for 7 days. Now, it was based off one paper of 1985. They didn't use this protocol, but they used some oral stuff that was similar. So it's a real extrapolation, but no one's been able to replicate it. However, if you talk to anyone that has used this, they will tell you that they've had some response. And I see responses consistently in the clinic all the time. So you wrap it up, you do it for 7 days, and it's meant to, because the peritendon is so superficial, it's really meant to help settle it down. So we use that in combination with heel raises, and I basically treat it like a stress fracture without the boot, where it's no loading, it's no running, it's no gym loading. You chock your heels when you're doing squats because it just needs to settle down. Like my partner had it, and it took 2 weeks of no activity at all to settle down, and then we did a graded reloading process where, with a tendon, we talk about a 3 or 4, the joke is tendon talk to us the next day. It should be a 3 or 4 out of bed, during the activity. With the peritendon, I say that, it should be a 1 at most. It really should be minimal, because if it's getting sorer, it's just going to get worse. Whereas a tendon's going to warm up and it's okay to have some of that pain with loading. But yeah, they're a nuisance. They're a nuisance.
When you get it with tip posts, so then you're putting that cream at a different location.
Yes, and it's not as superficial as the Achilles tendon. So as with anything in medicine, once something works so well, like, oh yeah, let's just extrapolate it out and let's just try it for everything. So I don't do it often for the tib post or the peroneal compared to the Achilles, because it's just so superficial, and the cream only goes down so far, like it doesn't go very deep. So for the tib post, it's a matter of doing the same things for the Achilles, but the idea of using inserts, they are significantly effective when we're trying to unload them. But thinking about, and I don't call them arch supports because I don't want people to think of them like an arch support. And I've got some shoes as an example here, where if we understand the loads, and you might have seen this logarithmic scale. Rich really was the one who I first saw it share it, where your options as a practitioner, and this is what I speak about with patients, getting them out of the pain phase. We kind of have 2 options when it comes to trying to reduce your loading. We can reduce the number of loading cycles that you take. And for us, as foot and ankle or below knee, it's either steps or, loading cycles in the gym. We can reduce the number that you do. So instead of doing 10,000 steps, you might do 8,000 or 6,000 and 5,000, if you identify it's load related. Or we can reduce the amount of stress per cycle. And when people start to understand that, it makes so much more sense. Because if we're looking at these 2 options, then what can we do? If you're a nurse on your feet with Achilles tendinopathy and you do 10,000 steps per day, and we can't change that, you have to do it for your work, what options do we have? We can't reduce the number of cycles, but we can reduce the stress per cycle. So every time you take a step, if I can have a shoe like this, that's off an 8 mil drop, and I put an 8 mil heel raise in there, I know clearly that I am unloading the Achilles. So instead of the Achilles getting, let's just call it 1, that amount of load, 10,000 times, it might get 0.7 or 0.6 with the right amount of unloading. And that would obviously reduce the amount of pain that someone gets, which is awesome. And it should allow them to do more loading because they're not as sore. They should wake up the next day a little bit better. Now, we don't have any research to say they get better quicker, but theoretically, we're thinking that they should. So that's such an easy thing to do with no associated risk, other than a little bit more load up at the knee, of course. And of course, you need to make sure they don't have any knee discomfort. But we can do that in combination with the loading, and sometimes just in isolation. So once people get that, they're like, oh, I get it. So this is why I have to wear my shoes around the house, because I might take 5,000 steps around the house over the week. That's 5,000 times or 2,500 times that we can unload that tissue that is obviously at the moment being overloaded. So why wouldn't we do it? So I get all my patients, go out and buy, I'm like, you can wear stilettos if you want. That's going to make your Achilles feel really good. But go out and get something that's really high in the heel, wear it around the house, wear it shopping, wear it when you're playing with your kids. When you go for your run, you can wear it, and we're just going to calm it down. Or even when we're loading it with rehab, it should allow us to do a little bit more extra exercise. Because you see people, they're walking around barefoot or they're walking around in flat shoes. And I'm like, this is an easy thing to do that we can implement right now. Why wouldn't we do it? And that's where we come into inserts and orthotics. It's the same thing. We can utilize these devices to reduce the stress per cycle to allow it to recover. And some people, based off they might have a degenerative tendon, metabolic disease, they might wear orthotics forever. And I use the example of medication. You would know type 1 diabetes, when you need to have, insulin. Type 2 diabetes, it can be managed with kind of lifestyle and medication. And then you can have kind of Panadol for a headache. So for me, people kind of sit into these three categories where the majority of people that I see are just like Panadol for a headache. We use the orthotic, but if I was to give you an orthotic now, Jake, let's say you come to see me with tib post pain and I give you an arch support or an orthotic or a load redistributor, there's this weird thing where you get that, and you were just saying it before, you almost feel like you're going to have that forever. If I give this to you, this is it. You're committed to this forever. Whereas if you broke your arm and I put a cast on your arm, you're coming out of that thing in 6 weeks. Once the bone heals, you're back to normal. But we don't really feel that with foot orthotics. And we're trying to get to the point where we can explain that to patients. So we use it, we unload your tendon, the tendon feels better, we start the rehab, we take the device out, and you're back to normal. Now, there's this second category of a bit like type 2 diabetes where a lot of people can manage their type 2 diabetes with lifestyle and good diet. And we know that very clearly from the research, but it's really hard for people to do. And we spend billions of dollars trying to get people to do this. And we're struggling to get people to meet their physical activity guidelines. So when I hear someone say to me, I'm in this orthotic, am I in this forever? I say, well, we can probably get out of this device, but you have to put in the hard work. You have to commit to the rehab. You might have to commit to managing your weight. You might have to commit to getting good sleep and drinking plenty of water. And really, you might have to commit to this for a year because this can take a really long time. And honestly, people will just look at me and say, I don't want to do that. I'm happy just to wear this piece of plastic. I'm happy to come back and see you, like every year you replace it or every couple of years and replace it. You've explained to me the options. Or I've already tried to do it and I can't do it. Is this okay? So, well, it's probably not going to be that harmful for you other than the cost. And it's about $150 to $600 every couple of years. I usually have a health fund that covers it. But I'm really open to saying we can do this, but this is the commitment and we can try. But I also can't guarantee that we will get to the end. And then the first category is the type 1 diabetes, where some people have these physiological changes within their body where whatever they do and whatever therapy they commit to, it's unlikely that they're going to get that change. And I see people with cerebral palsy and they wear an AFO, which is a big ankle foot orthoses. I see people with adult-acquired flat foot, midfoot away, a fused big toe, and the joint is degenerative. They don't have any joint space. The cartilage is really quite minimal, and their options are either surgery, which maybe they can't have, or try and go through the rehab, but it doesn't work that well. For those people, they might have to be an orthotic forever, and that's just how it is, and we need to have these conversations. So broadly, they fit into those categories. So for people with tib post and peroneal, I find that they're much more likely to fit into that category 2, where they might have a higher reliance on them, but really it's not that harmful. So orthotics aren't the devil. We can utilize them to really help people, and some people might have them for the long term.
Okay, when it comes to this, the settling the pain phase, the orthotic, is that like number one for you? You said NSAIDs and you said other things. Is that the number one thing you're looking at?
Oh no, I'm just the orthotic guy. Well, it depends on a lot of factors. It depends on how long they've had it for, and it depends on how much time they spend on their feet. And it depends on how painful it is. So if they've come to see me and this has been sore for a couple of weeks and it's quite minimal and they've had a big spike in load, I won't utilize a device because I think we've got a lot higher chance of just settling it with probably some taping and some footwear and some good load modification and then starting the rehab. But in podiatry, I don't see any real acute stuff. Usually they present to physio or they present to the doctor. So I usually see the persistence. So it's very unlikely for me to see someone that hasn't had pain for less than maybe 3 or 6 months. So I'm seeing it's in the chronic stage. So it's been going on for a while, and usually they've tried some of the exercise stuff and it didn't really help that much. And it's not that the exercise was wrong. It was just they weren't at the stage to be able to handle that because it was already too sore or it was just making things worse. So they need these unloading therapies. And once you explain to someone, or you put some tape on their foot and their symptoms feel a whole lot better, then it makes sense that we just need to settle it down. So I will utilize devices in those cases in combination usually with rehab, but depending on what phase they are. But you think of What are the potential adverse effects associated with the device? Minimal, because I can adjust them. I have basically an arts and craft room. I can grind and I can adjust and I can change it. Other than the cost, so we charge we have a medical grade foot orthotic, and I can build on. And I wish you could come into the clinic because we have a big grinder, and I just glue grind material on it. I can make it more supportive, less supportive, the arch higher, all that type of thing. And we charge about $150 for that. And it will last for 18 months. Whether they actually use it for 18 months, do they actually need it or not? And you can buy these online. They're form orthotics, they're called. And we have good research on how it reduces the load through the tissue. So once you explain that to someone, generally they're pretty happy to say, yeah, it's painful walking around. What can you do for me? And different to say you managing someone at the knee or up at the hip. If I I don't ever use foot orthosis ever for anyone with hip or back pain, other than, if they really want to and they've tried everything else. You can't really influence the hip with a device. If I'm not going to analyze someone's glute tendon with a foot orthotic, but I can really influence the tib post because an orthotic has its greatest influence over the subtalar joint. And that's the joint that the tibialis posterior controls. So I can really help them out with such an easy, low risk thing. So, it should be a part of the discussion. And ultimately it's the patient's decision.
You said, I'm sure people listening, so do they need their foot to get looked at? Or I think you had a post. Didn't you have an Instagram post of like if someone bought an orthotic at like Walmart or something, that there was good results or something like this? Or yeah, what do you look at for people that maybe they want to buy it online or yeah?
Yeah, well, this is the big one. If I say this, I might have to go into hiding because all the podiatrists might be after. I'm joking, you're joking. So there's this kind of school of thought. It used to come from, it has to be custom. You have to have a custom device. So you take a scan. We take scans now, 3D images, but you have a mold of the foot. And if you want to unload the tissue, it has to be made to the morphology of the foot. And if it's not going to be as good as an off-the-shelf one that comes pre-made. Now, there's merit in that because there are cases where we have researchers, so a custom orthotic will have more force application. If you imagine, I'm 100 kilos and I'm 6'5", if I pronate heavily, how much is the gel insert from the chemist going to really do to unload my tib post? Probably not a lot. And I see a lot of people that have those devices and they say that foot orthotics don't work because it wasn't enough of a force application. And it's the same with a tendon. If I go doing some calf stretches to make my Achilles tendon stiffer, and I go to you and say, oh, exercise didn't work, my Achilles didn't get stiffer. You're like, oh, no, it's just the dosage. The dosage wasn't high enough. And it's the same thing with foot orthosis. There's no difference. So we have these custom devices, and then we have these medical grade prefabricated ones. Now, they are made just like footwear. The companies have a mold of the foot, and they make the devices on that. Now, because it's the same basically mold or the same device, they're a little bit lower dose because it has to fit the majority of the market. Now, some people can get lucky, and it makes the exact shape of your foot. But now we have so many options in the market where you can get a good quality medical grade foot orthoses. I use Form Orthotics and Foot Bionics, and they are great. They have a big flare and arch that comes out, and they fit most people. And then we can play arts and crafts and add different material onto there. So the research at the moment isn't showing that custom orthotics are always superior. There are some cases where it is superior, like an adult acquired flat foot, where there's really physical changes to the tendon and the foot, and that's just because you need more force. But a lot of the time, we can use these medical grade devices and they help just as much because there's such a big window of effectiveness. Where it kind of boils down is if you say that load is a big factor, a custom device should theoretically, because it is stiffer, it should produce more force, so that should unload the force on the tissue high or more. But in the research, when we compare them, and it's hard because the studies aren't great and there's a lot of heterogeneity and there's different groups and it's really hard to do foot orthotic research because everyone makes these devices differently and the whole process to make them is differently. If I give you 10 calf raises and give someone else 10 calf raises, that's standardized. But if you have devices and foot orthotic, it's different because your foot shape is different, your arch is different, your heel height's different, depends on what shoe you wear it in, all these types of factors. So it's so hard to know. But my current opinion is that a lot of people would benefit from having these medical grade devices. And I don't think there would be any meaningful difference at the moment than using a custom device. And that's where I'm at now. And I just ran a 2-day foot orthotic course. So I've been through a lot of the research. And now I can't say that convincingly because we don't have those studies. So I can't sit here and say that my way is better. But I see it clinically, and based off what we understand, you can get a lot of benefit from just utilizing these medical grade devices. And they just need to have, as much of an arch. But Imagine for the peroneus longus, this is where the nuance comes in. If you have an arch support, what's that going to do to the peroneus longus? If you have more arch, it's going to tip them more laterally, which is going to load the tendon more. So that's why we don't call them arch supports anymore, because it's not about supporting the arch. It's about having force application to a tissue to unload that tissue. And if we understand what loads provoke the tissue, then we can start to make our design much more individualized. So if you come to see me for tib post, I might do a big medial flare so the arch comes up and around, a big wide heel cut. But if you come to see me with a peroneal, I'm going to do the opposite on the outside. So I'll do a lateral arch where it comes right up the outside of the foot, and I actually post it. So I've got all this material on the outside to wedge you over, and that significantly unloads your tendon. If you come to see me for heel pain, when you hit the ground, it's really sore on the heel, and the arch isn't as important, somewhat important, but I more want cushioning, dampening. If you come to see me for forefoot pain and your met head is sore, then I want to deflect and build material around that rather than so much of support your arch. So we don't want to call them arch supports. We want to call them force appliers or load redistributors. And that makes so much more sense because wherever the tissue load is, that's what I want to use the force and the material to unload that. So that's how we think about that like we do with every other tissue.
There's like a link I can put in the notes for this?
Yes. Yeah.
Okay.
So you just get them from Amazon. So you can get them from Amazon. So I work with lots of people online and lots of runners, and I'll say for an Achilles tendinopathy, it's standard. You need to have a high pitch shoe. You need to have some heel raisers, definitely. And depending on if it's peroneal or the outside, you should have one of these devices. Now, again, depending on their foot type and their biomechanics, I don't want to encourage people, you don't need a podiatrist or you don't need these devices, because a lot of people aren't going to find them comfortable. And so I can lower the arch height, and say for the outside, I might use a generic arch support with a big MLA. I might grind that down and then build support onto the outside. And if you go onto my socials page, I've got lots of examples of how we might do that. So even as an example, with big toe OA, we can, because we 3D print these orthotics now, I can extend the material under the big toe. So when you push off, you're not going to have as much pressure on the big toe. So we can do lots of really cool things for these peroneals and tipo. And I find that for some people, they really do need, for the ones that aren't settling, they can do really well with them. A lot of them will settle without them and you don't need them. But, you think, will someone benefit from that? I don't know if you've ever taped someone's foot. If you have someone with a peroneal or a tib post tendinopathy, taping works incredibly well. So what are you doing with tape? You're not changing the tissue. You're just changing the load on the tissue. And that's what I'm trying to do with an orthotic or shoes. And that's kind of how those principles apply.
That's what I was going to ask next. What does the taping look like?
Yes, the taping. And I love the taping because, I'm getting excited. I love talking about feet. So the awesome thing with the tape is when patients come to see me, I will get them their partner, or if it's a young boy, I'll get their mum and dad to come in and I get them to video me taping. And we have some taping on our video because the taping's self-directed. You can do that at home. How much is it going to cost you? $14 for a roll of tape. And you've got this clear, low risk, evidence-based treatment to help your tissue. You can't really do it for the Achilles, but for the tib post and peroneal we can. So you roll tape, $14. You need to use a rigid. I don't use the kinesio stuff. I don't buy into all the different whatever magic that people claim with kinesio. I want something rigid because a lot of force goes through these tissues. So the way to tape it is, if we again think back to the loads, well, what do we want to do? If I know the tib post is under the most amount of load with ankle dorsiflexion and pronation, and when I roll in, I want to tape the foot to roll out. So essentially what I want to do is I want to start with a roll of tape. I want to come from the outside of the foot and I want to tape it into eversion, because that's going to apply a supinatory force and that's going to oppose that pronation moment. And this is the rocket science. You need a PhD to be able to say this. What do we do for the other side? Of course, we just do the opposite. We just tape it to the other way and we unload those tendons. So I love it. And I get people to do 2 days on with tape, 2 days off, let their skin. You need to make sure you don't have a reaction. The adhesive can irritate the skin, but you can get some hyperfix to go underneath. And they can do that while they're at work. They can do that while they're playing basketball. They can do it when they go for their run. And they're able to modify their pain with shoes, sometimes with devices, very, very easily. And I find that it's so helpful to do. And if you've got enough mobility, you can get your foot around or someone else can tape it for you. So you tape around the side of the foot. I don't know, do you tell people to tape much for any of these lower limb tendons? You can't really do it much. For the patella tendon, you can. You do it much?
Yeah, but I mean, patellofemoral has that McConnell diamond taping that some people can benefit from, but no, you have a post or something I could link that video?
Yeah. I got the post. Yeah, it's awesome to do. And you just, whatever basically the movement that provokes it, we just try and tape it into the opposite. And you just play around with the level of tightness. And the greatest thing that I love telling people, it's the same with heel lift, the same with anything. we're not like injecting or doing surgery. So if something goes wrong and it's painful, you just don't do it anymore. And it's just a test. I'm telling everyone all these things that we're doing a test. So I hope we'll have to talk about footwear as well. But all these things are just really easy to do to make your life, basically live your life a little bit less pain, which is always great. Always great.
Yeah. Yeah. Okay. Yes. Let's stay on before we get to your other phases, like the rehab phases. Yeah, footwear. Are you looking at footwear with the post tib and the peroneals
Oh
and giving
yeah.
advice on that? Yeah.
Hell, yeah. Because I mean, I see like people come to see me and they have everything that they need that they can utilize. And I play around with different analogies, but and tell me what you think of this. You know, I know Greg Lehman talks about like the ecosystem of the body to be able to heal and recover. You know, getting good sleep and you're eating well and you're meeting your physical activity guidelines. For your painful tissue, we want to try and foster or create the best environment for that tissue to recover and to heal. And usually when someone comes to see us, they're doing too much loading and we need to do load modification. Education is a part of every research study. Everybody agrees that education is great. If your Achilles tendon is sore, what do we need to do less of? We probably need to do less of the faster rate of loading. If you're doing lots of hopping and skipping and running and it's getting sore, we probably need to aim to reduce that. So if we look to the other side of that graph of we say do less running, that's reducing the amount of cycles. But if we want to reduce the stress per cycle, footwear plays a massive role. So as an example, and I didn't put this on video, if you have a look at these two shoes, like you can see the difference between these two shoes. So this one's really quite flat. It's got a really narrow sole in through the middle here. Whereas something like this workhorse, that is huge in through there and it's got a nice heel pitch. So I wear barefoot shoes to work. This is what I wear to work. Just like an anatomical fitting, flat, flexible shoe. I don't have any pain. If we're thinking of, again, what loads provoke the tissue, if I want to make my tissue stronger when it's not painful, I should go, barefoot or wear a really minimalistic shoe because it's going to make my Achilles tendon stronger, my bone's going to get more load, below the knee is going to work a whole lot harder. But if I want to try and unload a tissue for the Achilles tendon, it all just comes down to pitch. So you want to make sure that the heel drop, which is the height at the back to the front, is, I say at least above 6 to 8 mil, and most shoes have that these days. So if you're wearing a flat shoe or thongs or barefoot, it's basically free load that you can modify to your tendon without doing much. And you're loading it all the time, walking around house, shopping, as we said before, work is a great example as well. So that's what you want to look for. And you want to pair that with, this is for the Achilles, you want to just make sure the foam, we call that the gerometer, isn't too soft. Because that's too soft, you're just going to drop in and compress it. And some people, don't know if you guys talk around shoes, but if you've got a soft enough shoe and it's a low enough pitch, when you hit the ground, you can actually drop into a negative heel drop, which, as you know, for an insertional Achilles, that's going to really, really stir it up. So easy thing to do, easy thing to change. And a lot of people already have. I'm like, go home, send me an email. What's the highest pitch shoe or the thickest shoe that you've got? Now, if we talk about the peroneal and the tib post, because the Achilles works mostly in the sagittal plane, the tib post is the peroneal pronation and supination. That's what we call the frontal plane. So I think, if you've got your wrist out, bending up and down, that's the sagittal plane, and rolling in and out, that's the frontal plane, and then side to side is the transverse plane. So the tib post and the peroneal work in the frontal plane. So if we think about shoes, well, what features of shoes are going to be most important? And you have a look at this, and a lot of people wear these slim shoes. How wide the sole is of your shoe determines a lot of the load that goes through those tendons. So if I have a really wide shoe like this, it means that I've got more surface area, more contact with the ground. So I'm going to have more ground reaction force underneath the foot. So I'm going to be more stable in the frontal plane. If I have a lot of material on the inside of my foot, I can't really pronate over that. Whereas I have a really, really slim shoe, you're just going to fall off the shoe and I'm going to really roll harder, and that's going to load the tib post. So we want to look for a shoe that's got we call it the gauge, but the sole of the shoe is wide through the midfoot. And the greatest example, if you've seen the racing shoes, like the marathon shoes, those things are so slim. So something like that, you're horrible, for your sore tendon at the moment. And of course you wouldn't wear that day to day anyway, but you want to look for these features of shoes. And when someone comes to see me, they come to see me for pain, and we're going to get to the rehab, of course, but in this pain phase, already on the first appointment, wear these shoes, maybe use this device, wear these heel lifts, here's the tape, and they are all mechanical things that are going to make their tissue feel better. They're going to have hopefully less pain day to day. And, you know, if you've ever had pain, it's nice to have something. These are something I can do. I can take control of these things and we're going to help them. And I haven't even got to the rehab at all the communication, all the loading, any of that stuff. So that's why I love the biomechanics in that respect, not from the sense of I love watching people walk and turn on their foot flat. I love understanding that because I can help these people on the initial appointment and they have something to go home with. And a lot of the time in that pain phase, I just do the education and they come back and they're a week or two better and they're significantly better. It's like you see someone with insertional Achilles and you say, you know what, for the first 2 weeks, I just want you to avoid ankle dorsiflexion. Chalk your place up when you do your squats, no jumping. If you're gardening, take out the gardening if you can. And they come back and they're way better. And all they've done is just reduce the compression of the insertion of the Achilles. So the loading stuff is just so important. And it's free stuff that you can do. Like they can do it themselves. You don't need any fancy equipment or device other than, you know, maybe $20 for some heel raisers.
Yeah. Yeah. I mean, I've had a number of those insertional where I'm just like, heel inserts. I don't even, maybe I talk about loading, but I'm like, just try it. And then so many of them just get better and you don't have to do anything different. And it is like, you don't need it forever. Let's just try to get it to settle down. But also my population is probably like younger athletes, not like the 60-year-old with diabetes and
do you
whatever.
talk about shoes much with those younger ones? Because a lot of them are just
it's just Achilles.
Or
I just see
thongs.
like the insertional Achilles, and I only release like that those papers on the heel inserts. So I'm like, let's just try it out, you know. But I don't do shoes because do you see shoes being an issue with some of these Achilles even?
Oh, well, I mean, I think shoes, because you think like if heel raises are effective, then shoes are just a heel raise in a better form.
Oh,
And the
okay.
difference with a shoe, so if you've got a thick shoe, so the thicker the material, it increases the longitudinal bending stiffness. So what that does is when you roll forward, it reduces the plantar flexor, like the torque around the ankle joint. So it reduces the plantar flexor force. So that's why, you know, I deal with a lot of bone stress in runners. And we know that plantar flexor is the biggest contributing load to bone. And same with the tib post, it is a plantar flexor. So if I have just this shoe here, it's got a thick sole, so it rocks them forward, and that's the rocker soled shoe, significantly reduces the load, plus it has the heel pitch, plus I can put heel raises in there. Now, it's not dose dependent of, you know, 8 mil in the shoe, 8 mil in the raise. That means you get double the pain relief. It doesn't work like that, but it's so easy to do, and people usually have these things at home. So I find I'm always talking shoes, and my advice to other health professionals and people listening to this with pain is, you know, look at home or make sure you evaluate their shoes, because it takes you 5 minutes to talk about it with them and they can implement it, and it doesn't take away from anything else. I'm not saying that we're not doing any rehab or anything like that. We're doing that in combination, but their tissue is going to feel better. You know, they're hopefully going to recover a bit quicker.
Okay. I'm staying on this. Maybe the pain location, because like I get the whole differential diagnosis thing with the anterior knee. I think for me, I'm always like the pain location is like just like where does it hurt, and I'm like, will tell me quad tendon, patellar, distal patellar, or maybe fat pad, maybe patellofemoral. But adding on top of this, I think it was Jill Cook who said it, of like all these tendons that you get these tendon pains where the tendon is wrapping around a bone, where you're getting the compressive plus the tensile load, and the exception being the mid portion of the Achilles, because there's no, it's not wrapping around anything, but maybe it's because the Achilles is so long and that's like the watershed zone. The tib post, the peroneals, is the pain or is the pathology, does it happen where they're wrapping around bones? Or are they different?
No, it happens where they're wrapping around, which is like as it comes down, you know, like the bony bumps on the inside and the outside of your ankle, the lateral mal, one's a part of the tibia, one's a fibula. They wrap around. The inside is the main one, the tarsal tunnel, as it wraps through there. That's the location where people most report pain, and it is the most avascular or reduced blood flow area of the tib post. I don't know about the perineal, but I definitely know for the tib post, the perineal is a little bit less studied. But then on the insertion of the tib post, which is the bony bump on the middle of your foot, which everyone you'll be able to feel that's the insertion of the tib post. So if you've got pain there, you still need to be careful though, because you can have pain there and it be in the navicular bone. So you just need to be careful there. But the tib post, because it crosses the ankle joint and the subtalar joint and some of the midfoot bones, because there's multiple insertions. Like the Achilles is just the insertion of the calb. The tib post is like you got some of the cuneiform, you got some of the base of the metatarsals, but the main insertions in the navicular, you'll see it in those areas. But again, you've got the joint underneath, you've got the flexor tendon, which we didn't speak about. Like you've got the flexor hallucis longus that runs right there. You got the tibial nerve, you got the lateral and medial branch off the tibial nerve. So you've got a lot more structures within there, and then you've got the medial malleoli bone. So you just got to make sure, I'm sure Jill and you would have said as well, you get them to do some tendon provoking activity, some hopping, and ask them to location. But I find for me that the subjective, I have an hour initials, and I can't see the justification at the moment to do 30 minutes or 40 minutes. I need to speak to someone for 20 to 25 minutes I need to understand when this happened, but I also need to understand what it's behaving like. Because if I just say to you as an example, if I say, listen, Jake, my tib post, that's where they come in, they tell you I've got tib post tendinopathy. Yeah, it feels awesome in the morning. And as I go for my run, it feels great at the run, but then it gets worse. It's just those two questions, I don't even have to look at their foot, touch their foot. You and I would both agree that's not typical of a tendon. It doesn't usually behave like that. So you need to ask these questions to see how it's behaving. And they say, yeah, I go for a run, it's a little bit sore. And then I've been getting night pain and I'm feeling it every step. I'm like, whoa, it's just a bone stress. That's not typical of a tendon either. So you got to spend the time asking these questions. And people just come in, they've Dr. Google, they go, yeah, my Achilles or my tib post or my peroneal sore. And I'm like, I'm sorry, we need to actually get a CT of your foot because I think you might have a navicular bone stress. Or I actually think you've got the posterior facet of your subtalar joint is sore. Or I don't know if you see this one as a common one. The back, they come in, they say they got mid-portion Achilles tendinopathy, and it's an os trigonum, or a stiter process, which is a bony protrusion from the back of their subtalar joint or their ankle. And that's not going to respond to loading, and that's really hard to unload, and they do quite well with a steroid injection. So you got to listen to that history. They're saying, yeah, it feels okay running and jumping, but when I kick the football, I see it in a lot of AFL players over in Australia, it's like plantar flexion, that's really low tendon load. You shouldn't be getting that discomfort, or the top of a calf raise, as like that shouldn't be sore for you. So you got to get it out of their history, because it can really can throw you.
I got an X-ray on my right ankle because when I sprained it playing basketball. So I landed on a guy's foot, he like closed out underneath me, which is like, you don't do that when you play basketball, but you play it pick up at LA Fitness. But guys are going to do that. It was bad for months. I couldn't walk for 2 weeks. Actually, I got an X-ray and I have the os trigonum on my right side, but it's never caused any symptoms. I've never had any issue with it. I think the one call I did have with a guy with the bursa, which one is it? Subcutaneous? Is it subcutaneous? Or which one is common?
The retrocalc, which Ebony, I saw Ebony speaking. She's like, it's kind of the same as an insertional. The anatomy is very, very similar. So, because that bursa. That guy, I think we got on a phone call and he was thinking he had insertional pain, and he was saying how bad it was when he's driving his car because it's his right foot. And I'm like, this doesn't line up at all. I'm like, and then he showed me a photo, and I'm like, dude, that is your bursa, and got him on like cutting a soccer player, cutting a hole out of his shoe. He actually bought a device. That's so cool. He got a device so he could drive with his left foot because the pressure of putting the heel on the ground was actually causing so much pain. And I was just like, let's just basically try to get this thing to settle down. I gave him a loading program because it was like, let's just do it because your calf is probably getting detrained now because you're not be able to play sport. But it's like, you just got to really remove everything that's hurting. But yeah, going in and thinking it's insertional pain, I'm probably going to give him loading and not pay any attention to anything else. It's like, for me, it wasn't hard I could see people missing it, but for me, it's like so clear that's like, this doesn't line up. Like this, and then hurting at night too, like putting pressure on it on when you're laying on your back and just having your heel sleeping on his back was causing a lot of issues. And it's like, that's not an insertional Achilles tendon pain. Yeah. That's it's funny those lines that come up. Yeah. Okay. Before we go on to rehab, I put up a Q&A and I had all these people. And I would feel bad if I didn't look at these. Look at these at least. I want to make sure there's not any here before we start getting to the rehab. This guy says, what causes it in runners? Have you already said that? Well, it's usually, I'll tell you in 3 years when I finish my PhD, but it's usually the majority of running injuries come from not running style or footwear or how you move or anything like that. It's usually just a matter of just doing too much to what the body can handle. And we know that these tissues and joint and tendon and bone, they take a really long time to remodel. So I usually say to people, you've got these, and I say this with other injuries as well, is, the rest of your body or your aerobic fitness is high up here, whereas your actual tissue fitness is very low. Now, your aerobic fit, you can feel great and feel fit, you're enjoying it, but your tissues take time to remodel. So if you increase your training load, let's just say you just increase your volume, your easy running, there's risk associated with that. But if you increase your intensity, we know that there's a significant increase in load to your tendon and your bone. So you need to be compared to just increasing your running volume. So usually it's doing too much too soon. Of course, there's some other factors involved, and injuries are multifaceted, but whether we're looking at how you run or your foot posture, whatever it may be, it's still a matter of you just need to give your time tissue to adapt. And I can say honestly, the majority of cases that I see, like rehab is certainly important, but it's just looking at their training load, modifying it, pulling on a couple of different levers, bringing them back down to a tolerable level, and then just slowly building them back up. And running's really easy because it's so monotonous, we can control it quite well. So it might be you're running 6 hours a week, we need to bring it down to 2 hours. Then we need to bring it up to 4 hours. Then we need to drop it back to 3 so we can add your session in where you might do 5 by 1K hard. Then we drop your volume again. Then we bring your volume back up, and we just kind of pull these levers to get you up to being able to handle the load. And that's basically the majority of my job. So usually it's just overtraining, which is like anything really. It's no different.
Yeah. Okay, that was from Jacob K. Worthy. I'll say the name just because this was actually a question I was going to have. Andrew.
Yeah.
Broderick 8 says it was on tears because you can have Achilles ruptures, patellar tendon ruptures.
Yes.
He says he has a split tear of the fibularis brevis longus. Success with conservative care.
Yes, yeah. So he's talking about the peroneal. Sometimes they call him the fibularis. In the textbook. So that's a good point. And I find, for me, clinically, I see this more in the tib post and the peroneals and the Achilles, where you do see these longitudinal split tears. And a lot of the time, they've tried to go through the loading, and it's just been provoked too much because it's still trying to remodel and change and basically become a part of the tendon. So when you have those tears, you just need to go slower. The challenge with them is they are hard to diagnose. So the clinical symptoms don't always fit unless they remember an incident and maybe there was some bruising and it's really painful. It's not that typical of a tendon. And unfortunately, the ultrasound, which can be unreliable, depends on the sonographer, the machine, they're really, really hard to miss. And we see this in the plantar fascia as well. And sometimes they can be overreported, underreported. So an MRI can give you a better detail, but even the MRIs aren't completely accurate. So I feel sorry for some people, and I've missed them before myself. They come through and they've had an okay response, but it's just hanging around for a while. They're otherwise healthy, and you think, why isn't this really improving? And it is something like a tear. So sometimes they do need to have surgery, or sometimes they just need to go a whole lot slower, and then we need to be a bit more aggressive with the deload. So that's a good example where for someone, I might use a custom orthotic because they're much more likely to have it for the longer term, and I need something that's going to unload their tendon quite a lot without putting them in a boot, or crutches and getting that detraining effect. So those ones you just need to go slower, and sometimes you need to be more aggressive where they might need to go and spend money on a custom orthotic and a really good shoe because they might need it for the next 6 to 12 months. Not always, but more likely.
While I look through some of these, I was going to ask earlier, you talked about the decreasing the load like per step. You said detraining. So there's detraining effect, putting someone in a boot. And
yeah,
I think I've never got to the point with the insertional Achilles of being like, let's try to decrease your step count. Because of the detraining effect, I'm just like, I feel like that's not good for metabolic health. It's probably not good for anything. What do you get to that point with people where you're like, I think we need to, if you're doing 10K steps, let's try and get you down to like 4K. Is that something you ever?
Yeah, so that probably, it's funny. It's so great, and your podcast does this, getting all these different ideas and opinions from people. So that for me, that's probably one of the biggest things that I do to talk to someone about initially, because I want to do this thing just like Panadol for a headache. And I'll look at, for the person sitting in front of me, what is your meaningful activity? Because I love people, and I really love some of the pain science and trying to empower people to understand what's going on with them. So someone comes to see me and my Achilles is sore, my tib post is sore, my foot is sore, and they're doing 10,000 steps. I know if they're telling me that on the days they do less and it feels better, can we just do that for a week or two just to settle it down? The first question for me is, listen, we need to reduce the load per step because it's sore at the moment. And at the moment, it seems like you're just doing too much. What's meaningful for you and what can we change? And what can we substitute? So an example, I had someone yesterday morning, and this doesn't happen that often, an older lady, a bit of metabolic things going on, peroneal tendinopathy for 6 months, but she's in a swim group, and this doesn't happen very often. She's in a swim group, so she loves to walk her dog. She's got her husband, so we spent all like 10 minutes talking about this. So now for the next 2 weeks, her husband's going to walk the dog, and instead of her walking, she's going to do more swim group. Because what do we know for swimming? It's significantly low peroneal load. So I'm trying to find throughout their week, can you go to the gym and get on the spin class? Can we go to the gym and do upper body? Can you go and do something that's low tendon load to reduce the, as you said, the detraining effect while we're recovering? Because I know as soon as it's settled down, then I can dose you with your activity. So we might go back and go, great, the tendon settled down. Can you just do 1 lap of the block? I know you want to get to 5 laps. Can we do 1 lap, then 2 laps, then 3 laps, and slowly build up? That's always the first option for people. And then the second option is sometimes, regardless of what we both want, we just have to reduce the training load. And we do it with runners. Like, we're very easy to say with runners, let's just reduce your load by a little bit, not stop running, but reduce it. So I think we should be doing it for people because I don't think the detraining effect is that significant compared to them having this chronic, injured, painful tissue for their quality of life. And I think the detraining effect, I don't think it's going to be that significant over 2 weeks to 4 weeks before I can then add it back in. And it's such an easy way to get them better. And usually when they come to see me, they've had pain for like months and months. So they're like, I just want to do whatever you tell me to do. What's the risk associated with it? Well, you're still doing activity and hopefully we can substitute. I don't think it's going to be that bad. Are you happy with that? Like, yeah, I'm happy to do that because then the retraining effect, they're not training at full capacity anyway. So it's not like they're getting the most out of their training. So I usually do load modification as part of my treatment. So I try and modify the cycle and then I also try and modify the stress per cycle as much as I can.
Okay, okay. Some of these are not fitting. So,
is there anyone that's just saying like, this is my friend has this pain and it's just their case? What should I do?
No, not yet. Here's maybe I don't know if this relates at all. It was Sing Swap 150. I was going to ask this myself. He's been suffering from plantar fasciitis 4 or 5 years. What could be the effective solution? So are there carryovers with plantar fascia and all these things you talked about?
Yeah, my colleague of mine, John Osborne, he's just finished his PhD on heel pain. Him and I just presented at a local conference on plantar heel pain. And it's funny, I would say without, not to say like an egotistical dick, but I think on the podcast, because this is the most common thing that I see. So I would see this at least 10 to 15 times a week. And I reckon I've seen that consistently for the last 6 years because it's the most common thing that we see in the foot. It's about 1 in 10 in the population. And it's a real nuisance because we used to say to people it resolves in 18 months to 2 years, but it seems to be longer. Although the people that I see, it doesn't seem to last that long. So there's a bit of disparity there. But anyway, all the treatments we have all perform about the same. We used to say, and we kind of still do say it, the plantar fascia is not a tendon. The physiology is different. But for some reason, we say just treat it like a tendon. We use the same pain parameters. We use the same loading protocol, like, the toe dorsiflexion, you do your raises and your holds, and you do your isometrics, but it's not a tendon. So I don't know why it's just kind of come from like, yeah, it's kind of like a tendon, but it's a completely different tissue. So the difference being that exercise, like we know exercise is really important for a tendon. It's not the same for the plantar fascia. There's been plenty of papers come out to show, which, this goes against my bias because I'm as Greg Lehman would say, a movement optimist. I love rehab. There is no difference between giving someone a quality exercise program and just giving them a custom foot orthotic and education. They're the same. They're the same. Of course, there's good benefits with plantar fasciitis. There's good benefits for exercise, but I say for these people, there's 2 types of plantar fasciitis usually. Have you heard of the 2 types, the compressive versus tensile? No. Oh, this is a good one. This is a good one. So plantar fascia starts from the medial tubercle, runs up to the base of the big toe. That's the medial band. You've got the middle band and the lateral band, which goes to the lesser toes. So in the clinic, and I encourage people to do this, if you have plantar heel pain, again, make sure you have the right diagnoses, that type of thing, not medical advice, etc. But if you see people, they get diagnosed as plantar fasciitis. We call it plantar heel pain now, more encompassing, but there seems to be 2 types in the clinic where when people walk, they have a lot of pain on their heel when they land. It's really uncomfortable. And if we're talking about the load, that's more compressive load on the heel. That seems to stir them up the most. Whereas you see this other type where people have it more in the arch, and you pull back your big toe, everyone's doing this now, you can feel the plantar fascia, and you get people, it's really odd, you get people to hop and jump with the more heel compressive type, and they have no pain in their arch. And if you think if you're hopping and jumping, that's pulling and tensiling your plantar fascia in the arch, and they don't have any pain at all. Whereas if you see the more tensile one, they have lots of pain when they hop. And then for the compressive one, you can get them, for the tensile one, you can get them to walk on their heels. They have no pain at all. They're like, oh, maybe a little bit, but minimal. For the more compressive type, they can't even put pressure on their heel. It's so, so painful. So I treat the heel pain one more like a bruise. And this is a good example where they have some detraining because it's been sore for a while, but exercise is really far down the road for me because it's just like a bruise. You can't rehab the fat pad. And if it's the heel coming down, you can do all the exercise in the world. It's not going to make that heel more tolerable because it's the heel strike that's painful. And as human beings, we have to put our heel out. It's about 1.2 times body weight. It's a lot of stress going through there. So in that example, we just want to cushion the heck out of it. And I've got a great video on my socials of doing the low-dye tape it. You want a big squishy shoe. Maybe you want an orthotic with lots of cushion. Now, all the barefoot enthusiasts, and I work with lots of barefoot people out there going, Blake, you're going to be killing them putting them in cushion shoes. So if you ever work with someone with heel pain, they don't care. It's just painful. They just want to get out of that pain phase. So I use all that in the pain phase to get them out of it. So my first question is always, what type of heel pain are we dealing with? Is it more compressive versus more tensile? And then that dictates our treatment. One, I heavily focus more on the rehab, a little bit more on the arch, more about arch support or arch contouring. Whereas the compressive type, it's more about trying to cushion. So I'll give you an example. UFOs or a thong. Do you have UFOs in the States? Do you have UFOs?
Yeah, I've seen them. Yeah, okay. Yeah, I've seen them.
Yeah, mate, if UFOs become more prominent for heel pain, I'm going to be out of a job. They are the most unbelievable shoe for people with compressive heel pain. And it's the same thing with the tib post, peroneal Achilles. Wear them all the time. Every time you take a step, it's a chance for us to influence the load. If we influence the load on the tissue, it should be able to recover and feel better. So wear them all the time. Wear your big squishy shoes. So always with plantar fasciitis, you just got to make sure you know which one you're dealing with. And you get that from the history. I remember I've had someone be able to run 20 kilometers a week with the compressive heel pain. They were a 4-foot striker and they were able to get through the pain. It was so painful and so sore because their heel wasn't hitting the ground. There was no compressive load, so they were okay. So you got to make sure you're dealing with the right one. So that's where I think in the history of if you've dealt with podiatrists, if you ever had someone let's say they have plantar fasciitis and they have a really hard orthotic that they hate, that's really rigid and stiff and hard, it's usually because it was the compressive heel pain and someone got a custom orthotic that was too firm and it's in a different device. We actually need one that's more soft versus more the tensile. We want it to be firm in the arch because that's going to reduce the pulling on the plantar fascia. So it even dictates our orthotics and it dictates our shoe and foot choice as well, footwear choice.
Yeah. Okay, no, I didn't know any of that stuff. I don't think I've seen any
Do you see much plantar fascia?
No.
Any calls?
I don't. I just stay away from it. It's a lot of knees and then some Achilles. I will go a little bit into Achilles, but no, the plantar fascia. I've kind of. I think Rich really talked briefly on it on our podcast, but that was it.
Yeah. What we did a podcast with Bradley O'Neill, patellofemoral researcher, and it's funny, foot orthoses like devices and the form orthotics, they are really well researched for patellofemoral pain. And I jokingly say with patients, there's probably more research that this is going to help for your knee, for patellofemoral pain that is, than what there is for the foot and the ankle. And he was saying the number needed to treat is 4. Now that sounds like a lot, as you need to treat 4 people for it to have a significant effect. But that's really high in research standards. So foot orthoses, and there's been some cool research at looking at even if you have a flat foot or a high arch, and we try and standardize the orthotic to your foot type, does that make a difference? And there's no difference, but it's still helpful. So I don't know if you use them a lot, but it's a well evidence-based treatment that you can just buy prefabricated off the shelf that's going to help people with patellofemoral pain. So physios manage it a lot. They just send to me, I put an orthotic, make sure it fits their shoe, maybe grind it, adjust it, then they go back into the physio and continue going on. And it's really helpful. And you can just buy them online. And the research is there. They did a study comparing foot orthoses to exercise, and they both were the same for patellofemoral pain, just foot orthoses on their own, nothing else, which is crazy.
What do you think it's doing?
Oh, I wish you didn't ask me that. So I could go into the real kinematic model. So I could say to you, listen, Jake, I know exactly what they're doing. What happens is you put the device underneath, it provides a supinatory moment. That reduces how much pronation. That reduces the tibial internal rotation by 4.2 degrees. That reduces how much knee flexion you have at the knee. That stops the patella from tracking laterally, and that reduces the patellofemoral joint. And while we're at it, it reduces the internal rotation up at the hip. Now that's the kinematic model that we used to prescribe on. I obviously never say that to patients, and we don't really know that's happening. It could be, but we don't really know. What I say is it is very likely influencing the loads at the foot, and it's just shifting load away from the area that's sore. I don't exactly know where the load's going, and we need to be safe in making sure we're not just moving load to somewhere that's sore. But I think it's doing something by reducing the amount of knee flexion by you're compensating by modifying something at the subtalar joint and the ankle joint, but mostly the subtalar. Because you get someone to pronate and supinate barefoot, you see their knees go in, like you see their knee move. So there's obviously some biomechanical effect, but it's so hard to measure. All I know it helps, and it's so low risk, and there's really nothing that's really associated badly other than, the cost and the potential for it not to work. But based off the research, it's something that's certainly worthwhile trialing in a condition that happens, a lot. It's the most common injury that we see in runners.
Okay.
Yeah. And basketballers, basketballers as well.
Yeah. No, that's not a good question. Pain with weight bearing on the peroneal side. T. Caravolus 67. Yeah.
Yeah, 67. So pain with weight bearing. So you need to be careful. Is this going to be video or is this going to be?
It'll be video. It'll be YouTube too. Yeah.
Oh, heck yeah. Actually, I love having the foot model. So let me just make my camera not blurry. So we were saying before, there's not really, with the Achilles, I'm just thinking with the knee, I guess you got the tibial plateau, but you don't have any high risk. You don't have any high risk bone stress around the knee. So again, just speaking like the severity of injury, what's the worst case scenario? And because I work with the medical sports doctors, you just hear of the really bad cases where someone's had pain for a long time, no one got it imaged, and it turns out to be cancer. Like you need to sometimes, again, rule out all the nasty red flags like we do with back pain. And just because it's the foot or just because it's the knee, it doesn't mean these in osteosarcoma, all these things can't happen. So, we say that we don't want to image people or over image them, but sometimes if things aren't responding, we need to just get a bit better of an idea. Not so much to say that imaging tells us the diagnosis, but just to make sure it's something not nasty. And a great example, and this is a real frustration. So the base of the fifth, so you're just saying pain, that person's got pain with weight bearing. So if that's all they told me, they had pain with weight bearing with the peroneal tendon, my first question for them would be, what is the location? Because if it's on the outside, if it's on the if it's on the outside of the ankle, it's much more likely to be the tendon. You obviously got the fibula there. You need to make sure it's the fibula. You've got, again, the posterior part of the of the subtalar joint. You've also got the calcaneocuboid joint, and joints are very, very common to be injured. But if someone says I have pain with weight bearing down the outside of my foot, the peroneus brevis inserts onto the base of the fifth metatarsal. We have a high risk bone stress injury in that site. Now, if I push onto the base there, if your tendon's sore or you have a stress fracture or a bone stress, I'm not going to know. I'm not going to be able to know because I'm pushing into the same structure. So I need to make sure it's the right diagnosis. So I then ask, do you have pain with night? Do you have pain every step? Has there been a big increase in your training load? Usually it's in runners, but you're trying to get an idea because you just don't know. And then if I'm still not sure, we have to get an MRI. Now, an MRI in that case is going to give us a diagnosis in the sense of it's going to be clear that it's not a stress fracture, and you're probably going to have some tendinopathic changes. So that's where imaging, can be really important. And we use imaging a lot in the foot and the ankle. I use imaging a lot. I have access to an MRI machine just up the road. People can get it same day or the next day, depending on if it's the outside. If it's pain with every step, another great example is what we spoke about. You're in the pain phase. We need to get you out of that pain phase because if you just give more loading, sometimes isometric can help, but not always. If you give them slow tendon loading, maybe it's just going to make it sore. So we need to figure out, I would be getting you into a shoe that's got a big wide sole, try to get you in a heel raise. And these raises I was talking about, you can also have varus and valgus wedges. So you can have a wedge that's built into the shoe and it's really high on the outside. So that's going to increase the pronatory moment, and you can have really high on the inside. So you can utilize those. And the greatest thing is you just buy them off Amazon. They're like $10 and you can just put them under the sole of the shoe. So they go underneath, they stick in, and you can sit it on there and you have a clear, helpful modality to unload that. So I would be doing, make sure you get the right diagnosis, probably see a health practitioner, then use a wedge, use a shoe, utilize the taping, and you're probably going to get, halfway there. And you might need to do that for 2 weeks to a month to settle it down before you start the loading.
Hmm. Okay. The maybe this is good. Patrick Nowakzek. Tibialis posterior
Patrick.
tendonitis. This is more compression or more strain related?
Yeah, so it's still the same as the Achilles. Like you've got tensile load and compressive load. You've got tensile load in through, the tarsal tunnel and further up where you come from muscle to tendon. But you have those compressive loads on the navicular, tensile load and compressive load in through the tarsal tunnel. And then you have also those high loads, just like an insertional Achilles, at the base of the navicular tuberosity where the tendon inserts. So it's still a combination of both. Now, you can reduce some of those compressive loads, as I said, with a heel lift, because you increase the amount of ankle dorsiflexion, so you don't have as much subtalar joint pronation. And all these devices too, think a heel lift, an orthotic, a wedge, it will apply force to the foot that will change or try to influence the joint position. And then whatever crosses that joint, in this case soft tissue, it's going to influence the load through those. Now, whatever anyone says, if we're looking at 5 degrees versus 6 degrees and trying to look visually, we know what we see visually isn't a great representation of what's happening internally. And I hate using this word, but correct you with a 10-degree wedge. And internally, it's probably only changing it by maybe 2 or 3 degrees. So it doesn't actually work that well, but we know that it can help people with pain. So it's more compression and tension, tensile, just like it is for the Achilles. The only thing I would add, I don't know if you see many plantaris. I see a few plantaris. That's a unique one where you have the plantaris and the Achilles tendon and they're rubbing together, and you have that shearing load, which is obviously it's another tendon load. You can have some shearing loading through the tarsal tunnel because the tib post runs next to the flexor tendons and it runs near some soft tissue. The Tom, Dick, and Very Nervous Harry is the tibial nerve, the flexor nerve, the tib post. And it's what we teach at the uni to the students as it runs through the tarsal tunnel. So if one of them thicken, there's a tenosynovitis, you can have some of that shearing load, and that can be really quite painful for people. And that's a good example where how do you reduce the shearing load for an Achilles and a plantaris? An orthotic isn't going to do anything for that. Maybe footwear and heel lift, but it's different to then trying to manage that loading wise, where we're just a lot less aggressive because we need to slowly develop that tolerance, just like we need to do with a peritendon. And there's an awesome study. I always quote this at the start of every conference, and I'll ask you this question. They took it's like 70 or 120 people with chronic mid-portion Achilles tendinopathy into surgery. This is it's an Alfredson study. So they take them into surgery. They think they have mid-portion Achilles tendinopathy. They go into the surgery. I want you to tell me, just off the top of your head, how many of those people do you think had completely pristine, beautiful mid-portion Achilles tendinopathy with no tendinopathic changes, which we know you obviously have to then have the tendon pain, usually, most generally speaking.
So how many people had a good looking tendon, you're saying?
So they thought you had mid-portion Achilles, we take you into surgery, we open you up to check your tendon. How many of those do you think, so basically it wasn't the tendon, but how many of those do you think had a healthy
man,
healthy tendon?
Probably quite a few. Are you getting at the plantaris involvement?
Yeah, so it was 1 in 5 had completely normal mid-portion Achilles and a tendinopathic plantaris. So to think, I've seen 5 Achilles this week easily. To think that 1 in 5 of those, and obviously mid-portion, 1 in 5 of those, potentially when I was younger and still now, hopefully a little bit less as I'm getting a bit more experience, but that these diagnoses, these differentials are out there, and you can have some fatty infiltration and some neural ingrowth between the plantar. I did a webinar on it, and they've done some awesome histological studies where they look between the tendons, and it's like this neural hypersensitivity that's going on within there, but I find that is amazing to think that they've had this ongoing Achilles pain, and it was actually something else. And I know you had Derek Griffin on, and it's similar with the back. There was an awesome study where they had undiagnosed back pain, and it was something ridiculous. Like they hypothesized between 24 to 64% of them had an inflammatory disease, and it wasn't just the non-specific lower back pain. So we've got to get clear. And I know we say that diagnosis isn't everything, but it does matter for me when it changes the diagnosis. And I have this one guy on Instagram who I have this massive argument with. It's like, it doesn't matter about the diagnosis. It's all about unloading and reloading. That's all it is. That's all the principles are. And I get that, and I agree with that. that. But I'm like, if someone comes in and they have a bone stress injury, you're treating that differently. If it's higher risk, they're in crutches and a boot for 6 weeks, or you're getting a CT and MRI. If it's just a typical tendon, then we're going to be doing something differently. So it does matter to a degree, and we need to get a bit clearer on that. And I wonder if any other people like Greg and things will listen to this, because I go back and forth between not using a diagnosis like calling it plantar heel pain, or because we don't have any accurate tests to say I can tell you what structure it is. There's no special test, but having an idea of, well, this is what provokes it. I just need to be clear. I think it's this tissue, and it matters for this case. So I'm going to tell you. And we have the research to say that patients do want a diagnosis. We just need to be clear in the way that we communicate what's going on. So we might say for the back, I can clear the nasty things out of there, which is great. So I can tell you what's not going on, and it might be a bit more disc-related or facet-related. And we can say the same thing with the ankle, but sometimes it really does matter. And the clinic that I work in, and again with the doctors, because they're like the last point of call. They're seeing the physio, they're seeing the podiatrist, they're seeing everyone else, and it gets to the medical practitioner and they get an MRI and they're like, oh yeah, it was an inflammatory disease, or they get blood, or the physio or the podiatrist rehabbed their Achilles tendon for 12 months and did shockwave and did all this stuff, and they had like ankylosing spondyloarthropathy or an inflammatory arthropathy, or it was an Achilles tendon that got treated for months and months and months, and it was the plantaris or the peritendon. So we've got to get clear on that. So that's why it's so important. You just got to spend the time. I mean, I used to do 30-minute initials when I first started, and I think of how many people, and I feel bad for them. I think of how many people I probably misdiagnosed because I just didn't spend the time with them really understanding, just from ignorance, because I didn't really know.
Yeah. I mean, I'm not even in that space. I just look from the outside, but I think it's got to be like the pendulum swing that people were so hyper focused on imaging, and then it's like now they say it doesn't matter. It's just anterior knee pain, and let's just let it settle and then build them up. But it's like, I mean, you maybe work with someone who has anterior knee pain for 2 years, and I'm going to be like, okay, that approach probably didn't work. So let's figure out what's maybe you need a better diagnosis, but. You know,
Yeah,
I feel like
if
it's
it does
just
change, and sometimes it changes, and you can, you get that, like, I wonder if those people, because I agree, like, we don't, and I think they're coming from, like, we don't have the special test where I push into your patellofemoral joint and it's 100% specific and accurate to say, yes, you have patellofemoral joint. And I completely agree with that. We don't have any cluster of tests that, bring it all together and say, yes, 100% you have this going on. But we can make an educated guess, which I think is well within the evidence, and then we can treat based off and help that person based off an educated guess, because there are certainly times where it does matter, and not all the time, but sometimes. So I think it's okay to do that.
okay. This guy T. Lewin, podcast open to public? Yes. Okay, I'm not going to ask any more of these because it's going. We've already been like almost 90 minutes. The rehab. Okay, they're out of that pain phase. What are you?
Yes.
Yeah, what are you doing? I mean, how are you looking at this? Because I was going to ask earlier these are more of those positional tendons versus like the big energy storage like Achilles and patellar.
Yeah,
So it's like,
for sure.
what matters for rehab? Are you really looking at like we need to load this really heavy? What's your rehab look like?
Yeah, so because the insertion is different, so we know that they're frontal plane and sagittal plane. Now, of course, they're a bit more involved in the frontal plane. So the rehab is very, very similar to the Achilles. The difference is, and if we're talking generally, we kind of move through this phased approach, and that's not for everyone. But these tendons, I don't do this with the Achilles. I never get someone doing banded plantar flexion with an Achilles. I just don't seem to think it's worthwhile, because it's just that the load is so low. I'm like, if you walked in here, you probably don't need to be doing banded plantar flexion. You've probably got enough force for that. So I like to get people doing banded inversion and eversion, and I really want them to be. It's critical that the setup is appropriate, because if you're just seated now, knees at 90 degrees, and your hips at 90 degrees, and you get someone to do inversion, so you get them to lift their foot to dorsiflex and lift it up and come in and out, people will naturally just internally rotate their knee, and they just basically use their hip rather than their actual foot. And you need to make sure, although they are bands, you need to have plenty of resistance. So I like to get people to lay with your legs flat, 90 degrees on your hip at 90 degrees, legs flat on the floor. And let's say you're doing your right leg, you'll bring your left leg over, so your left leg will hold your knee, and then you're getting them to just lift up a little bit. And then what you're getting them to do is push in and down, and that's plantar flexion and inversion. And what you want them to do is be able to have the band pull the foot all the way out as much eversion as you can. And you have about a 2-to-1 ratio of inversion to eversion. So you want to go all the way out so you're maximally everted. That's where the band's tight. And then you're going from that position all the way in. Now, you should be able to get pretty far. Now, what you might find, I don't know if and you said this a little bit with the Achilles, but you find at that end range, they start to get some shakes, and that's what we want to be able to train. So we want them to be able to go fluidly from eversion, maximally everted, to complete inversion. And I usually like to start with either 3 sets of 10, 3 sets of 15. And ideally, we're doing it sometimes twice a day, but usually every day, because they're smaller tendons. And I find that this helps with the pain, getting it moving. And of course, if you're doing isotonic, you can do inversion as well. So I'm much more likely to get people started with that. It gets them doing something. I like to bring in some of the foot stuff a lot more. Like, you get in to do some big toe flexion with the band as well. So the band underneath. I don't do any foot intrinsics or arch doming, because the research is suggesting at the moment that the foot intrinsics are such small muscles that the strain, it's not that important. So if someone can, like, doing arch doming is about the equivalent of walking. So it's like, well, if they're walking, I just don't think it's that worthwhile. I know the barefoot people that are listening to go, it's really important to get coordination, all that type of stuff. I'm like, you can just do it with balance. It's not that high load, and it's not what I'm trying to, it's not the stimulus I'm looking for. So I'm not going to be doing that. So then I progress them on to doing some calf raises. Now, there isn't a person in the clinic that I will see that's not doing a calf raise, because everything below the knee is obviously related to the plantar flexors. The difference that I'll try to do, depending on the phase that they're at, so I'll start with, and you've had some really smart people on talking around their loading programs. I keep it relatively easy, where I'm just going to get them doing usually some isometrics where they're up nice and high, and then I'll bring them down a little bit shorter to they're about neutral, and then I'll get them doing some isotonics. Usually they're just doing it with body weight, because again, the loads for pain, it's not that difference between medium loads to high load. And then I start to add in some weight when we transition to performance. The difference being, once we're in that capacity phase and they're tolerating it, we can start to bias the tib post and the peroneal. So sometimes I'll get people to, because when they come down, they should pronate a little bit. I'll get people to hold at the bottom and maximally pronate, and that's going to lengthen that tendon a little bit more. So I'm trying to get them not down for the ankles, for the Achilles. Sorry, they're down into max dorsiflexion. I'll get them to go into dorsiflexion, into pronation, to try and lengthen the tendon. And then for the peroneal, what I'll get them to do is I'll get them on a, the slant boards. Mm-hmm. I'll get them on a slant board, and I'll get them to come up so the big toe is raised up so they're on an angle, and I'll get them to go up on a calf raise and to supinate. So those are the ones that I'll bring in. And then the other one, which, listen, I can't sit here and say that this is any better than just doing a calf raise, and honestly, from the research at the moment, it's probably not. The other one that I like, and it feels a bit Instagrammy for this exercise, is you get them to have the band, and depending on if it's the inverted or the everted, you get them to put the band around their, let's say, their right leg. They stand out so the band is pulling them in, and then you get them to go through a calf raise. So it's pulling them into pronation and supination. And obviously you can do the other side as well. So when you come down, it's pulling you down and you're trying to oppose that. So theoretically, you're using those other tendons a little bit more. So that's probably the only difference, where I'll start with some bander stuff, and the bander stuff really can work quite well. Then I'll progress them to some isometrics, some isotonics, just like everyone else does. And then I'll try and bias and get them into those positions, because they need to get into those positions. Now, when I'm loading them back into the plyometrics, different for the Achilles, I want to get them to do side to side. And one of my favorite tests to get them to basically see the deficit between either side is I'll get them to, so I'll basically have about 18 centimeters, bit of tape, 8 centimeters apart, and I'll give them 30 seconds to hop on either side of the tape. And we want to aim between 45 to 60. So basically 30-second hop test side to side. And that brings in the peroneals and the tib posts a lot, because they're going side to side. And when they hit the ground, they're really pronating, they're really supinating, they're really pronating. So for me, I use that.
That's just one leg.
Yeah, just one leg. So I aim for 45 to 65 compared to other side. How does it feel? That's about the highest tendon load that you can do, obviously, other than, sprinting and things, but in a controlled environment. So I like to use that test to see what the deficit is if you don't have access to equipment. And you see some people, like they can't get the number, they get like 20, or they just can't do it because it's painful, or they can't jump the height. And it really shows them. And the 30 seconds brings in the fatigue element. Most people can do 5 to 10, but if you're getting them doing upwards of 20, 30, 40, 50, and 60, and you want to do it as quick as possible, that's what I'll get them to do. So it doesn't change too much for the Achilles. And then, it's the same, tendon rehab as you talk about, then shifting more to the stiffness, get in to do those higher lows, get in to do some isometries. I love isometries because it's less muscle damage to the calf than doing like an eccentric. But obviously they've got to be at that, out of that kind of, or the back end of that capacity phase, and then they're usually back to normal.
So it's
Good.
you have that pain phase, and then you have it's capacity phase, or no? What's the next phase?
So this is the most hotly debated, the minimum effective dose phase. So it's a phase of figuring out all the things that we use in the capacity phase and the pain phase. How much do you, this person sitting in front of me, how much do you need to rely on them or utilize them to stay at this phase of where you want to be? So you will see people, and I see people all the time, that for some reason they just feel like if they don't do their exercises once or twice a week for their tendon, and my partner's an example, she has an insertional Achilles. If she doesn't do her isometrics heavy, her tendon pain comes back. It's really odd. And she's doing all the right loading. She runs about 60, 70 Ks a week. And for some people, like, yeah, listen, Blake, I've everything's going really fine as long as I do my exercises once a week. And for some people, they don't ever need to do that. They don't need to go to the gym. They just get back to it and they're back to normal. And I'm like, well, you make this decision. I'm moving now towards the phase of everyone that I work with, and your page is a great example of this, where it makes theoretical sense that when someone comes to see me, I want to manage their condition and their pain, but I want to show them and convince them that exercise is good for them. And as well as I do, resistance training is like the elixir to older age. My recommendation now is everybody should be resistance training if they can do it. I know not everyone loves the gym, but doing something, because having stronger muscles, more energy reserve as you get older, we know sarcopenia, it's not just muscle loss, it's power loss, it's bone density. All these things happen as you get older, and they're happening now. We can blunt some of this or even maintain by doing as little as 3 sets per week. And there was a study that came out, 3 sets per week, which is amazing. I know there was one study I love to quote where they get someone to just squeeze their forearm for it's like 20 seconds once a day for 5 days. And that showed like significant effects to their grip strength than the other arm. So like just squeezing your arm for 20 seconds, just do something. So I'm trying to get people to do that. So I say now for the capacity phase, and this is what my PhD is on at the moment, is can we say to people that are asymptomatic, or once they come through this phase, so let's say you manage someone with patellofemoral, or I manage someone with a tendon injury, they get back to their everything, their 100%. Can I say to them, based off the evidence, that it is smart for you to maintain good quality, heavy tendon loading that's going to make your tendon stiffer and maybe just better quality? And does that mean that you're less likely to get injured? You're going to have less time off? Because at the moment, we can't say that a training program for your tendon, although we can have these changes, is protective against injury. I'm not aware of any studies that show that. I know there's one to say people have tendinopathy, they're more likely to rupture and go on to develop it, but that doesn't tell us about the physical characteristics. So this is basically a part of what my PhD is on, because we have some awesome protocols that make tendons stiffer, and we can say clearly that higher strain protocols are better than lower strain, and it makes so much sense. But in the human body, time and time again, the research shows us that we are probably wrong. So that's what I basically want to try and figure out.
Okay, we talk about this.
I mean, you would say that it's protective, right? You would say that. Like, it's good to do. It's smart to do. Like, train your tendon.
Yeah, I think it is. And but yeah, how do you know? How do you know it's protective? It's hard to get data. It's like getting data on injury prevention, Like I think good strength and conditioning prevents tendon injuries, but you can't get data on injury prevention like that, because it's just you talked about the high strain. So like, are you concerned with that, with these positional tendons getting a lot of strain in the training? Because what's the research? They say like the energy storage can strain, the ultimate strain can be in the double digits, like patellar and Achilles, but then like these positional ones is like the ultimate strain's like what, 5% or something along those lines.
It's a little bit lower, and again that hasn't been, to my knowledge, that hasn't been researched in the tib post and the peroneal. We honestly we extrapolate a lot out from the Achilles, so it's obviously it's a little bit less, and of course you can't load you can't kind of bias these tendons because anytime you're trying to have high strain, you're going to have ankle dorsiflexion. So you're going to have strain on the Achilles. So it's not like it's all theoretical. And it's the same with the Achilles as well. It's not all just through the Achilles tendon. Obviously, there's other loads. There's a joint capsule, there's tendons, that type of thing. So I will just use the person as the subject, where let's try and get you to as much as you can tolerate, as long as it's roughly over that 70% and it's challenging. So my typical protocol for people is 2 to 3 times a week, 3 to 4 sets of anywhere from 6 to 8 repetitions with 2 reps in reserve. That's my like isotonic. And then my isometric is we're aiming for the tendon stiff protocols that I'm aware of, it's 4 sets of 5, 3 seconds hard, maximal voluntary contraction over 90%, 3-second rest, repeating that 4 times, which is 1 rep, 4 reps for 5 sets. And in that protocol, it's 3 to 4 times a week. So I basically just get people to do an isotonic and an isometric twice a week. That's my minimum effective dose for a healthy tendon for all of these. So someone gets back, a runner, someone gets back to me, I go, great. What do we need to maintain now? There are some stimuluses, and we spoke about this online. There are some stimuluses that we just can't seem to get from running because of the faster loads being applied. And we know that runners, they do not have these awesome, springy, thick, strong tendons that we see that other, active powerlifters and things have. So I'd say twice a week, I want you in the gym doing one isometric protocol and then one isotonic protocol based off those two. And I can say that both of them have been researched to increase tendon stiffness. Obviously, it's different protocols, but the isometric one, that was done in well-trained runners. Like it was done in a cohort that I'm working with a lot. So I think it's smart for people to do that. I did a post. I know Peter just did a post as well. We know that tendinopathic tendons are less stiff, so they elongate more for the same amount of force. And if we say that tendon length, more tendon load comes from more tendon length, then theoretically, maybe if your tendon's lengthening less, it should be less tendon load. So maybe if we get enough people, hopefully for my PhD, fingers crossed, it could be protective against tendon injury or recurrent tendon injuries because they're bloody common.
In your rehab, so like I think the guy I'm thinking of is my friend David Gray, Gary Ward. I think Joel Smith is the strength coach too. They have those wedges. I don't know if you're aware, like, and they do these movements where like they put a wedge maybe at the heel and then one like more forefoot, and they're going through like supination, pronation, inversion, eversion movements. Is that something you ever use? Or no?
Well,
do you know what I'm talking? Do you know what I'm talking about? Do you know
I know exactly what you're talking about. Yeah. I know what you're talking about, and I'm just at the moment I'm not convinced. I feel like it's a bit Instagrammy, where it looks awesome and it looks really specific. I mean, people that I work with in the clinic, they're not going to be setting up for that. Now, could I say that if I really convinced them and it was superior and it was actually, this is way superior to anything else, well, of course, then I would convince them. But I don't think the tissues are that specific. I think there's such a big window of effectiveness. One thing that I will use, and someone you have on the podcast who's Romanian, I can't remember his last name, but he did his PhD in first MPJ function. And one of the things I like to get people to do to engage the foot a little bit more is I'll get them on a slant board doing, say, a normal isometric somewhat max plantar flexion position, but on a slant board, they'll have the big toe engage. And we know when the forefoot or the toes are extended, it makes the foot stiffer. So theoretically, it's going to engage the foot a little bit more. So I'll get them on a slant board, pushing hard isometrically, a bit like Peter's protocol, 10 to 15 seconds, really max contraction, or the 3 seconds on, 3 seconds off with the big toe plantar flex. And I find that as the last stage, it can be really helpful for people as well. And that brings the foot into it a little bit more. With those different funny positions, I don't know. I mean, I've seen some of the stuff from other people, not from them specifically, from others, where there's a lot of theoretical jump of, well, this is the best position the foot should be in. We don't know the best position the foot's going to be in. And if you're just trying to bias the tendon, well, I could probably just bias it by just dropping down off a step and inverting or everting, or coming up and inverting and everting. And I just don't think that specific way to load in that position is going to be superior to doing it as we just said. And I know there's a study that just come out from Joe Kemp that Peter Maliarish was talking about online, where they did state-of-the-art tendon rehab for, I think it was for a hamstring versus just general exercise, and there was no difference. So there are sometimes specifics matter, but I don't know about those wedges and things like that. Like, I think it's just, maybe it makes it a bit more engaging, but I think you can just stick to the stuff that we already know that's helpful. Yeah. What do you think?
Yeah. Okay. I mean, so this even makes me think of, you're aware of Bill Hartman?
Yeah.
Bill
Yeah.
Hartman in Indianapolis, and I mean, I've went through his content, and like generally, if I'm gonna, I get more confused the more I go through it because I just, yeah, it's really complex. But I think he has this idea of like relative motions. You know, if you don't have relative motions at certain joints, and I think of the feet having all the bones, if you don't have relative motions, maybe you're gonna overload certain aspects over the other ones. So like this and they probably would disagree, but like you get stuck, like quote unquote stuck in certain positions. So maybe they're trying to do stuff like that.
Yeah.
Do you think that's a
But what,
thing?
like, what? Yeah. Well, I mean, because you
Because
say,
I'm
and it's
thinking of that
hard.
idea of being
Yeah.
stuck is
Yeah.
like you think of someone with that foot posture where they're just really pronated or they're rigid, really rigid and supinated, and it's like that.
Yeah.
I guess the idea is like it doesn't matter the foot posture, but it's like can you get in and out of these different ranges of motion? So I think that's
Yeah.
why they're trying to justify
Yeah.
these things. But for you, have you
Which makes
seen? Do
sense.
you see people that are like they literally can't get into ranges, or is that really not a thing?
Mm. Well, like this is it still go. I don't know if it's based off this, but it goes back to like so the old theoretical models of the foot was, and this is, and there's an awesome paper called Chasing Footprints in Time. I encourage everyone that manages the foot to read it, and it goes through all the models of how we thought the foot functioned, and they weren't based on any good quality human studies that were done over a long period of time. It was the best that we had at the time. Don't get me wrong, but the idea, and if you still see this online, the idea that the foot is a mobile adapter and a rigid lever is gone. It's dead. That's not how we think of the foot anymore. So if people are still telling that and using that, it's like, we've got to train it as a rigid lever. It doesn't happen like that. The foot is this dynamic structure, and it's dynamic through the whole phase of gait, and it's incredibly variable, and we cannot predict it. We've tried to predict it. We use foot posture, we use dynamic and static, and we're all over the place. So it's really hard to predict. So even what we see visually, again, doesn't determine what's going on. So when we know that's the case, what I find really troubling is if we're talking about being stuck and having relative motion, I'm like, well, how much? How much are you talking to me? How much range of motion? So if I say, Jake, tell me right now between my intermediate and lateral cuneiform, in between that joint, exactly how much range do I have? Because you know that those joints are, let's say the subtalar joint as an example, triplanar joint. How much range do I need to be a functioning human? It's in the transverse plane, the sagittal plane, and the frontal plane. It's a triplanar joint. It's roughly about 42 degrees from the axis rotation for the subtalar joint. It can be incredibly variable. So how much are you telling me that this rehab program gets you from 46 to 39? And that's what I'm encouraging. So, and then when we say, I know you're saying quite like stuck as in not physically together, but are you saying it's like an equinus? Because I see people with a coalition and they physically, their bones are fused together, that their tarsals are together. And the only way that's coming apart is with surgery. So are they stuck, or are you talking about they can't get into the movement because it's painful, or they've just never gone into that movement? Because it's like, how are you, if they're, let's say they're stuck in supination, so you're telling me that you're making them pronate, and then you're telling me that your exercise is going to encourage them to do that. So when they walk, they're going to start pronating, because wouldn't they just walk? Wouldn't they just pronate when they walk anyway? Why is your exercise different? So there's all these questions that just don't make a lot of sense to me. And I think if you were to sit down with a quality, I guess someone who understands biomechanics, there's lots of questions to ask about this different type of training, because when you're online, you can say anything. And honestly, I don't have the time to sit there and write a comment. I hate writing stuff. I'd much rather talk to someone like this, because you can get at those conversations. So, and I know there's a guy on Instagram. He's the only guy that I'll actually say his name, because I don't like to call people out. His name's Connor Harris, and he, like, I've just got him on mute on Instagram because he puts out some crazy stuff about internal rotation and all this biomechanical kinematic model. And it's honestly, it's what we did 60 years ago, rebranded in a new course with some fancy Instagram stuff of, you don't have internal rotation. That means you can't get into the hip. That means your femur doesn't sit in the acetabulum right. And that's why you have FAI. You know, things like that, which just don't make a lot of sense. So if you're trying to tell me that you know how you should make the foot function, I'm going to have to call you out on that, because some of the best researchers that get millions of dollars, Luke Kelly's a great example. He's a really famous researcher here in Australia on the foot. If he's saying that he can't predict foot function, I don't know about this guy on Instagram telling me that he can. So I'm probably going to listen to that researcher. So in saying that, it doesn't mean that you can't train them and do all these things and help people, and it still help, but it's probably just not in the way that we say it. It's the same with back pain or whatever. We say these narratives and ideas to people, which hopefully, they don't grab onto, but it can still help them. It's just whether it's actually happening in that way. So I don't discourage that training, and it helps so many people, and that's awesome, and I love that. But it doesn't mean that it's generalizable. And if you really was to actually have a discussion with someone who's really knowledgeable in that field, I just don't think it would go down that well.
Mm. Yeah.
Yeah.
Yep.
Yeah. And again, I don't know if it's any different to then just doing a calf raise or just, doing some walking. I don't do a lot of mobility drills because you look at the foot. So I'll give you an example, a quarter of all our bones and joints are in our foot. That's insane. A quarter of them. And look at the surface area. The surface area compared to the body, we have so many bones and joint. It's so hard to predict their function. Of course, you want to encourage more movement, but I don't know how you're targeting one joint. Like, are you targeting just the midfoot, the tendinovicular, calcaneocuboid, this part of the subtalar joint? Are you targeting the DIPJ of the fifth or the second? Like, it's really hard to be that specific with the foot. So I think training it general is probably good enough at the moment, and sometimes the specific format for the high performers. But for the majority of people I work with, and I imagine the people listening to this, they're going to be okay just training it heavy, training it with that toe pushed up, and doing those heavy isometrics and heavy isotonics.
Mm-hmm. Yeah, that's probably that movement optimist approach of, like, I think you said earlier with the if you present in a certain way, it's like, how do you know that you can't adapt to that? How do you know it's going to be a maladaptation if you have if you're loading the tib post more because of the way that you're moving? How do you know that your body just can't adapt to that?
Yeah. Hey, the amount of people that I see in the clinic that have no pain that come to see me for their flat feet, because previously in the army, flat feet was a diagnosis. It was like a diagnosis, like this is a pathology. And don't get me wrong, I don't want to say flat feet, but a pronated foot posture, it is a risk factor. We know it's a risk factor for MTSS. There's a risk factor for some other conditions within the foot and ankle, because that way that foot is put together, it does determine a little bit of the loading. So we can say, yes, because your foot's flatter, you may have more pronatory excursion. That's going to load the plantar flexors more. We know plantar flexion is related to shin splints or MTSS, which I see a ton of. So that's obviously more likely to happen than, say, a peroneal tendinopathy, which we would say the same thing if they had a laterally loading foot type. So it gives us a bit of an idea. And when someone comes in and says, do you think I have a flat foot? So I tell people now, this is my terminology, because I like to have a go. I say, great, you actually don't have a flat foot. You have an adaptable, normal, variable foot posture. That's what I call it now, because I'm like, it's adapted, it's normal, it's just variable within the average. And people are like, haven't thought of it that way. People just still call it a flat foot, but I'm like, I want you to think about it differently. It's not a flat foot. It's just a bit of the out of the variation, but it's a strong, adapted posture, and let's make it strong. Let's make it capable, because I'm not going to change it, and I'm certainly not going to send you to surgery to change it. And the greatest thing is, you come to see me, Jack, I say, your foot doesn't need to change for you to get better. So what's the point of focusing on it? And guess what? Your pain only started 4 months ago, but your foot's been flat for the last 45 years. So why didn't we have any pain back then? Why was it just in the last 3 months? So I love to just get these ideas, flowing for people, because it's a lot. And a lot of my job is just trying to de-escalate what they think about their anatomy and their biomechanics.
I had this question on your rehab, because you get it with the Achilles. The seated calf raise more for the soleus, standing, kind of hitting both. Are you does it have any effect on peroneals and tib post if you're in a seated or a standing?
Yeah, because you are going to get, it's the same, it's not the same, but you are, and again, when we're talking more for the high performers and people that want to get back to a little bit more and want to do everything, I will get them doing the seated, because with the seated, if you set, and it's a lot easier to set you up positionally. For some people, it's really hard because they go so heavy that they can't even have the pads on their legs, and it is a lot more common in females. So I will use the standing. But the idea with the seated one, which is good, is you can get into a lot of ankle dorsiflexion, and you can really load up. It's a lot more comfortable to then pronate and supinate. And I feel you can be a lot more controlled because you're seated, because you're kind of taking out a little bit more of the balance. So I will use that if they have access to it within the gym. But again, I don't find it's that much of a difference, other than what you just said with just hitting the soleus a little bit more. But they can just load into like you can really heavily pronate and maximally dorsiflex on a seated machine. I think a little bit more, and it's a little bit more comfortable for people, and they can just be a little bit more controlled because we said we don't want to load too fast or too heavily initially. So I find it's just a bit easier to do.
Yeah.
Yeah,
Yeah, and
yeah,
I mean, for me, I think I have some plantaris involvement because straight leg, heavy dorsiflexion, like, does not feel good on my Achilles, but I can do seated. I can go as heavy as possible. I have no issues. I can go into
yeah.
the
Do you
deepest.
feel like a string, or what do you feel when you do it?
Yeah, it just doesn't feel good, and it's more medial, like mid portion. So I just put it all together, and I'm
Yeah,
like, it's probably some
yeah.
like plantaris involvement. So I'm like, heavy. Yeah, I just kind of I'd maybe bend if I'm doing standing, I'll bend the knee a tiny bit, just make sure I'm not locked out, and then also I won't go like really deep dorsiflexion. But on the
Deep. Yeah.
on the seated soles, yeah, the only problem there is like, is it how bad does it hurt my thighs, the pad, because
Oh,
that's
I know.
limit
And
how
if you
heavy I
get
can
out,
go.
you're a strong person. It's painful. I mean, I'm a little weakly. My calves, they're not even, they're not cows. They're calves for sure. Like I'm okay. But the heavier people, like the people that can go heavier, they're bloody loading up their thighs. And if you have people like patellofemoral pain as well, like even sometimes the padding can irritate the top of the knee. They got to bring it right back. Yeah. That's it's good. It's good.
Okay, this is almost 2 hours. I said 1 hour, but we just keep going.
Yeah.
I had a question.
How good.
One of the questions was on ankle stiffness. So like maybe a performance measure. When people have this tib post or this peroneal, does it
Mm.
affect their performance? If they're like an explosive athlete who really needs ankle stiffness, like a good Achilles and calf,
Yeah.
does it affect
Yeah.
that? Obviously if they're painful, it's going to affect them, but like, does it take away from this ability to have the stiffness at the ankle?
Yeah, definitely. We find like the people just they really struggle. Usually when they're in, if it's let's say running's a little bit different, but if it's a cutting sport and there's a change of direction sport, I find a lot of people have a lot of trouble when they're in like going from say neutral to almost max plantar flexion in that range when they're towing off. They've got a peroneal issue or a tib post issue. I'm finding because they control so much in the frontal plane, they really have a lot of time and they just over supinate and sprain their ankle. And you'd be aware like chronic ankle instability and things like that, a lot of the time these injuries they get missed, and ankle sprains are some of the most common injuries in the world, and they just get put down. It's just, oh yeah, it's just an ankle sprain. You rest for a bit, take some anti-inflammatories, do all this protocol and get back to some activity, and they never truly go through the rehab, and they have associated ligament damage, but they also have some tendon damage, some joint injuries. Sometimes they can have an osteochondral defect, and people can have and go on to develop this chronic ankle instability, and people don't often always assess it to the degree of their sport. So if you come to see me with a sore ankle, and let's say you have reduced ankle stiffness, I might not see it if I just do isometric compare, 10 calf raises, 10 calf raises, and I'm like, oh yeah, it looks pretty similar. You look pretty similar. It's not until you need to test them until you really get them up to change of direction, bringing a ball into it, taking them down to the oval and getting them to do this spinning, and like you get them to run circles and S-bend and doing all these activities, or you're getting them to jump so you can do the 3-legged hop, straight forward. You get them to do side to side. You can get them to walk, do like a farmer's carry up really high and watch them walk down to the end. And you just see their foot when it hits the ground, they just like supinate, but they roll their foot out when they're in that position. And you can see, and they say, Blake, it feels different. It's not painful, but it feels different. And we do need to bring that in to train them. And we see that associated with ankle sprains, with tib post and peroneal. So just like when I see runners in the clinic, every runner that comes to see me on the initial appointment, I just need to watch them run a little bit just to make sure there's nothing too asymmetrical or odd or different. Then we do a proper running assessment. But if someone's come to see you for soccer or AFL or sport, and they're doing okay, and they're just seeing you maybe a little bit of pain, you need to see them as close to their environment as you can. Obviously, when they're in the pain phase, not so much. It's okay. We're just trying to get them out of that phase. But you need to be able to test them. Like I have a big, beautiful gym and running track, and we can do all this testing with them. But you need to be able to see what they're like under that stress, because you just can't get the representation. If you do a controlled heavy calf race for someone, you might see some changes, but you need to see how do they perform when they're changing direction and running. And obviously, we over in Australia, we do a lot of AFL and rugby league. I mean, in the ideal world, you see someone running at them, trying to tackle them, and that's what you really want to see, what their ankle is going to be like under that amount of stress. Now, we can't replicate that in the clinic, but we can get pretty close. I can get someone running at me and I can say left, go right, and I can watch, I can visualize it, I can film it, and we can see how it's looking. Now, again, we're probably going to see some asymmetry, but you want to see how does it feel, and you want to see something, grossly asymmetrical. And then whatever deficit you see, then you want to start to bring that in. So a really common one for me I like to get people to do is that farmer's carry. You get them up on their toes, band around their toes really tight as you can, so it's making them wobble. And usually it's 10 or 15 kilos on either side, and you get them walking down 15 meters and 15 meters back, and they're trying to have that resistance. So the band hits them, and the band will try and pull them in, and they're resisting it going out, and they're trying to keep muscles straight with some heavy isometrics, with the hopping side to side, and then obviously with some gain direction stuff and some drills. And, honestly, for the people I'm working with now, there are people that are better at me than that in that high performance stage. So I try to identify it, and then I just say, listen, it's really important you go and see someone that just has the time and the energy, and honestly, they're just better at it than me. So I want you to see them because they're just better. I can do it, but go and see them. So you need to make sure we get those deficits, because when they come back, you have to think that there is an association why their risk of injury is so much higher. Not all of it, but ankle sprains, once you have one, you're much more common to have another one. Tendinopathy, all these things, you're much more likely to have them again. We know the clearest risk factor is you've had it before. A part of that has to be we just didn't get the rehab right to the end, I think.
Mm-hmm.
So yeah, it's important.
Okay, last one I got for you is, you said everything you do is lower limb, and you said shin splints or medial MTSS.
Yes, the
what's
shins. We're going to be here. We're going to be here all weekend after this.
What's going on there? I've got a few questions on those. I mean, over the years, and I'm always like, the easy cop out is just say too much too soon. Too much too soon. Be smarter about it. But yeah, what's going on there? How do you help those people?
Yeah. So the cop out for me when someone asks that, they say, it depends. And then just leave it at that. So depending on what theory you buy into, at the moment with my current understanding of it, and I see this, I mean, I love seeing MTSS, like medial tibial stress syndrome or shin splint, or the new term is limp, lower leg induced medial pain, whichever one you want to call it. It's one of my favorite things to see in the clinic because it is one of the most common things that we see in runners. It can be a real nuisance. People can have it for a really long time. So it's a fun condition to work with. Not fun for people to have it. It's really painful. But at the moment, my current thinking is it is an entheopathy, where it is that periosteum around the tibia, and we're having some structure. I think it's the deep plantar flexors having some shearing, compression, some force applying to that, and that is getting sore. And it seems to be, and it would make sense that it's associated, and a risk factor is having a flatter foot posture or more pronatory excursion, which would make those deep plantar flexors that start laterally come down and cross at that point and insert onto the inside of the foot. They do run in that area, and there's been some anatomical studies to show that. Again, there's some variation, but that seems to be where I'm at. So it's an entheopathy. Now, I don't know, and I'm going to ask you this as well, knowing that, and it's similar to the patellofemoral joint, these structures, would you agree? And I don't know what, I've been trying to figure out a term, not involuntary, but these structures' physiology is different. Like a joint has a different physiology to a tendon or a muscle. Like they adapt differently. And I think it's to do with how they adapt, where I think that the entheopathy or the shin itself, it just needs the exposure to the loading cycles. So I don't know if there's a good argument in the saying that someone with shin splints doesn't need any specific exercise. They just need a graded loading program. Because if I say, what are you trying to accomplish with a calf raise with shin splints, right? Make the calf stronger. If the load that aggravates the shin is the load against, let's just call it the periosteum for argument's sake. And let's say you grant me that for this argument to make sense. It's the loading cycle. And we just spoken before about, the amount of cycles per tissue. If it's a number of loading cycles that it can handle. Once it gets to say 3,000, anything over that makes it sore. If I'm doing calf raises and I'm hopping and jumping for my rehab, it's just loading cycles, right? Because the tissue is just mechanical sensitive. So if it's just loading cycles, why instead of that, why don't I just use running? Does the body know the difference between running and doing a calf raise? So the most people I work with, I just really deload them. And they say, well, Blake, when are we doing the rehab? Say, well, your rehab, which is going to be maybe 200 loading cycles of calf raises and hopping, why don't we just get you out doing that, with your running? Now, 200 is obviously a lot low and you can't run very far with that amount. But I'm thinking to myself, it's maybe not so important. It's just you have a certain number of loading cycles you can handle. And as long as I'm underneath that, we should be able to increase that over time. And honestly, if it is the patellofemoral joint, I think it's the same thing. Because what are you trying to accomplish with doing, say, squats with patellofemoral joint? It's still the loading cycles in the joint, and it's a different adaptation to a tendon and muscle. So I think to myself, if we compare, and again, I want to do this with a prospective study, and I know it's been done in patellofemoral pain, but it wasn't that good of a study. If we compare just a loading program that's graded versus a really quality exercise program, if we just control the loads, is it going to be the same? Because what do you think? What do you think of that? Does that make sense?
Yeah, yeah, it does. Because if you're talking about the shin splints, and it's like that's not a structure that adapts like a muscle or a tendon,
Yeah.
like there's not,
It,
yeah,
it just
if
knows
it's
load.
just,
It just knows the loading cycle. And if
yeah,
you're under that, you're good.
and yeah,
Mm.
similar with like, I guess with patellofemoral, you do have the multiplications of body weight, like going upstairs is less body weights and like jumping or cutting, so like, you know what I mean?
Yeah, yeah.
But
Yep.
does that exist for the shin? Is it,
Yeah, for
if
sure.
you
Like
run
it's
faster is
significantly
going to
more.
be more? So it's like,
Yeah.
yeah, is it loading cycles and like intensity?
Yep.
Like the both of
Yep.
those, because then I would think if you have 200 loading cycles, you're going to get them from calf raises. Do people get shin splints from calf raises? You know, or do they get it from
Yeah,
running?
yeah. From running.
Yeah,
And you have to assume that it's just because running, it's a lot more loading cycles. But say for the tibia,
yeah,
we know that
more, yeah.
for
So you'd have to do
yeah, so
calf raises at the similar amount of volume, and then see if we can get
yeah,
shin
yeah,
splints that way.
exactly.
Yeah,
Yeah, so it's
yeah.
like, could you do this big loading program? Because I just think, like, say for the tibia, it's about, and we know muscle forces contribute to bone load. Tibial bone loads with running is about 9 times body weight. 7 of that comes from muscle forces, 2 from kind of ground reaction force. And then when you're jumping and cutting and playing basketball, it's up to 14 times. So it's a lot more load through the plantar flexors as you do more intensity. Steph, my PT, put up an awesome post. As you increase your intensity from like 530 per K to 430 per K, it's a significant increase in bone load. And that's why when we're looking at running, intensity below the knee is the key, and running uphill because more equal dorsiflexion. So we always need to be careful with intensity. But thinking of that, like if you're saying someone needs to be doing their rehab, every day, and it's just load is all that tissue knows, what's more specific to them building capacity than doing the activity? You talk about calf raises and hopping, preparing you for running. I wonder how well running will prepare you for more running if it's controlled, So I think to myself, there's nothing more specific than that. And same with the knee as well. If the patellofemoral joint is sore and we're giving you some loading, why not just give you, some walking to start with? But when you get to the point of handling running, could we just give you a graded walk run program? And that's building your capacity to handle your need to handle the load, because it's exposing it to the exact load and the exact amount that it's going to be compared to the squats and raises. So now in my rehab, for performance-wise, I give plyometrics because they're helpful. But in the rehab phase, I'm not giving anyone with shin splints plyometrics. I'm just giving them running because I'm like, your body is getting the plyometric exposure through running. I'll give you some calf raises because we have some detraining and all that type of stuff anyway. But I'm wondering in the initial phases for people, and this is the same for the Achilles, when I'm starting someone running, sometimes I'll take away all the rehab and just use, because I'm like, at the moment, you just need to get exposure and capacity to loading cycles, and there's nothing more specific than your meaningful activity, and it gives people lots of options. So I'm not convinced of that, but I hope people listening it like, oh yeah, the periosteum, if it just knows stress and I just control the stress, maybe I just need a good loading program that's well within my limits and I can prove that over time, and it's going to be just as good as an exercise program. So that's my my current thoughts.
Yeah. Yeah, my activities is dunking basketballs, and it's like I could do all of the training in the world, and if I don't keep dunking consistent, it's gonna blow up my knees. It's not gonna feel good.
Yeah.
And
Yeah.
I've heard of a number of case reports of people with patellar tendon or patellofemoral just rehabbing with dunking. Like instead of a 10-foot rim,
Mm.
they do it on 8-foot rim,
Yeah, yeah.
So it's like
Yeah.
you're just
Yeah.
jumping lower. And I gave advice. I had he's not a professional dunker now, but he's probably going to get to that point, a single leg guy, that I think he had a really bad injury. I don't know if he partially tore it, and rehab was going really smooth, but I'm just like, you need to be getting on the court multiple times a week, and dunking on a lower rim. Like, make sure it's not painful, but it's like, if you take this away for 3 months, it's going to be really hard for us to get back to this after 3 months. So I think you need to be keeping this in along with good rehab, because we know that I want to build your quad muscles back. I want to keep your calf muscles strong. And if you have
Yeah.
inhibition from pain, and also dunking is not a good way to build up your quad muscles to make them bigger and stronger. Like lifting weights is much better. So,
Yeah.
but yeah, no, I always have that in my head where I'm just like, what is the goal activity? And that might be from Greg Lehman kind of has that idea
Yeah.
too of just like, well,
Yeah.
can we just prepare? Can we just do the thing to prepare for the thing? Do we need to do
But
all this quote unquote
yeah,
prep work? You know, and I think
it's
something with
hard for
the
dunking.
tibia, something with the tibia
Mm.
is like that's we know that muscles work and tendons work differently based on the speed of contraction, but like the bone, I guess you do get quite a bit more bone strain from like those fast things, really really impactful things, because that muscle's really working hard. But yeah, does the bone know the difference? You know, like I don't think it
Well,
does.
yeah, this boggles, and my partner is hopefully going to do some research on this, and I really want to have, I don't know if Rich listens to this, but I'd love him to have back on the podcast, because last time I spoke to him, I don't feel like I was knowing as much as what I do now. But this is a great example where someone with a bone stress injury, they need to do rehab, but this is a little bit different. I was just talking specific for shin pain, as
Mhm.
using their meaningful activity, do the thing to do the thing. Whereas a bone's a bit different, where we know that runners, that their bone mineral density is just about as good as the average population, because running, it's not great at building bones, and runners should be, and they can improve their bone mineral density if they're doing really simple heavy squats, heavy calf raises, and some hopping and jumping. But because it's all about the muscle contraction. But isn't it funny to think then, well, if running is such high muscle force, as we just said, 7-9 times body weight, and when you run, the muscle will contract, which will load the tibia. We just spoke about, 9 times body weight, but roughly about 7 from muscle force is the tibia. So why doesn't running build bone density? Is it because there's too many loading cycles? You talk about the McKenna transduction dampening, but if you have these high muscle forces with running, and muscle force is a big contributing factor, why do we not see that runners just have the biggest bones on earth, whereas bone stress injuries are so common? Is it because there's so many, or is it the first 40 loading cycles you get all the benefit, then the bone kind of goes deaf and you don't get any benefit after that, and then it becomes negative for you? Like maybe after 2,000 loading cycles, which might be like a 2K run, and you're going for a 10 or 20K, it starts to eat away at the bone and there's more bone damage. So maybe it is good for your bone, but because you're doing so much accumulative damage, it kind of negates that, and you'll end up as a net negative. Does that make sense? Like you would think it would be.
Yeah, yeah, because that's that work with the 10 minutes of activity is anabolic, and then it becomes catabolic for the bones. But then
Yeah.
you have the multi-directional, like the runners run in a straight line, and they get growth in like one direction. So you're probably hitting the same cells. But what if you did a multi-directional sport? Now you're probably getting like 360-degree shin growth. So it's like
Yeah.
like Keith Barr had that with tendons, where it's like first 10 minutes they adapt and then they shut off for 6 hours. But I always wondered, I'm like, how many billions or trillions of cells are in your tendon? And are you telling me that 10 minutes of activity signaled every single one of those cells? Or what if you did a
Yeah.
leg extension for the patellar tendon for 10 minutes, and then you did a squat for 10 minutes, and you did a jump for 10 minutes? Are those not going to be hitting different cells within the tendon? So we're going to be continuing to get adaptation. And if not, I would think all the track and field programs that worked with jumpers would have really bad patellar tendons, because they only trained them for 10 minutes and then everything else was catabolic. So I've questioned it from the
Yeah.
tendon perspective, but from the bone perspective, it's like, I don't care enough about bone, so I've never questioned it. But I'm like, yeah, wouldn't you think that these ultra marathon runners would have awful bones, because they did 10 minutes of anabolic activity and then they did hours of catabolic activity? Like,
Hours and hours of it. Yeah.
yeah.
Yeah. And there might
So
be something to do with REDS, relative energy efficiency in sport, which you and I were talking about online, where we know that's a huge one in bone. Some studies show up to 1 in 2 females will have relative energy efficiency in sport. And that's a huge one, because it has a whole host of effects, not just to the bone. And we know metabolic health is so important for tendons. I work with lots of runners, and now with any runner that I'm working with, whether it's tendon or bone, I'm getting them to do the screening questionnaire, because I just have an assumption that REDS is going to affect their tendon health, because we know it's so important for bone. It makes sense that it should be important for tendon. Like it's still within the body, and you still need the energy for the tendon to remodel and go through that process. So why wouldn't we? But it's never really
yeah,
talked about for tendon.
I know I've been trying to figure that out, and then even the bone stuff is like they want carbohydrates, you know? So like even if you get a lot of calories through fats and proteins,
Yep.
they still want carbohydrates. So then I'm like, for tendons, do they want carbohydrates? Because I've heard anecdotes of people going on carnivore diets, which is like no carbohydrates, and feeling much better in tendons. But I'm also like, we would need to get a MRI or ultrasound or something on the tendons to see what happens before and after, because you feeling better in your tendons could have been a billion things. You went on carnivore diet, you
Yeah.
could have been getting better sleep, you could have been doing a bunch of different things. So I'm like, I don't know anything about protein, carbohydrate, fat, and what does the tendon want, you know? But you're probably on the right.
Yeah.
That's probably the safest track, just to say what is the bone like and dislike, and then the tendon probably is following
Similar.
the same
Yeah.
pattern. Yeah. Yeah.
But we have that for bone where like it's really clear where we know, you know, when's the bone bad? When it's fractured, you know, or when you have bone edema associated with pain. And we know people can have bone edema with no pain, but we seem to be a lot clearer on the physiology. So if I was to say to you, what's the bone equivalent of a tendon? What's the bone mineral density equivalent of a tendon? I don't really know what that is. Like we say that bone mineral density higher is better. Too high is not good, but we have osteopenia, osteoporosis. If you come in and your Z-score is this, here's all this stuff. The doctors are on board. Everyone's like, we need to get you up here. Your fracture risk is so high. We need to get you into the healthy zone. Whereas you come to send me for a tendon, you can have a whole host of things going on. Let's say a tear, we'll rule out the tear, but you could have a really degenerative tendon, all this stuff, and we're kind of like, you know, the current consensus is, well, I don't know what's good and what's bad. Let's just use your symptoms. So we don't really know what we're trying to do. So maybe, like, even with the red S stuff, we don't know what we're trying to see as the change. So is it stiffness? We know that the morphological stuff doesn't always match the mechanical stuff. So if we get an image of a tendon, it's not recommended because we don't really know what we're looking for. I know Peter's done some stuff and he's recommended about the modulus, but it's trying to like treat, you know, the idea of treat the donut, not the whole. But maybe if we can understand the whole donut, we might be able to then give some protocols to make it a bit like tendon stiffness. But I can't say to someone, you get it stiffer, you're going to be better, compared to if I say, if we get your bone mineral density higher, that is definitely better for you, for sure. And everybody agrees with that, including the doctors. So we don't have the same for tendons yet.
Yeah. I look at the tendons too, and I'm like, I think if you look at the tendon hierarchy, like it's so complex that maybe that's why it's so difficult to know. Because like bone is not that complex. Muscle, I guess, muscle's not either. Like I use like tendon biopsy or muscle biopsy. You do a muscle biopsy and the person has some pain, but they recover quickly. You do a tendon biopsy and you're messed up for a year or two because to get that hierarchy back is so difficult. So there needs to be some type of measure with tendons, but I think what makes it hard is the lack of getting samples of living humans, because who's going to sacrifice their tendon, their Achilles or patella?
Surely, Jay, that if you want to get to 1 million followers, you need to do a story of where you give your tendon, because your tendon's been trained pretty well. You give your tendon to research, and then you just do like day 1 of no tendon, day 2 of this tendon, and you just slowly see it grow back, and we learn something cool.
What I have done, I got a UTC scan of my left patellar tendon recently. Cool. In Michigan. My friend Trent Salo has one, and it's a mess, dude. And I just look back at the dunking, playing basketball and dunking is like, for one summer, I dunked like for 2 months every day straight, just because.
Wow.
Because I wanted to.
Yeah.
And it's like waking up in the morning, pain, stiffness, going on the court, pain, stiffness, but warming up. I warm up every time and I'm fine. I go dunk. And then it's like afterwards I was usually fine next morning. So it's like, I purposely gave myself like really bad pathology in my patellar tendons because I'm just a jumper. And I think you look at national NBA data, and a lot of them have really pathological patellar tendons because anyone who plays basketball for 10 or 20 years, they're probably going to have really pathological patellar tendons. They might not have pain, but I think they're going to be pathological because the sport just bangs up your patellar tendons like crazy, and everyone walks on the court stiff as a board, feeling terrible, and they warm up a bit and they feel good, and then they go play. So it's like you use the tendon warm-up effect, and then you annihilate your patellar tendon. So I'm lucky I haven't ruptured yet, because my tendon I should have got my right one looked at too, because it was just like,
are you going to do a protocol and then re-image it? You got to do that.
I'm gonna go back
to him. I'm
gonna go back to him at some point and do that. And it also makes me think too, I've taken a lot of time off of dunking and jumping, and it's like it's hard to get back into it when I do take time off. But I actually
Mm.
think there's got to be a therapeutic effect on the structure to actually doing the thing, you know? Like I could just
Oh,
do
for
all the
sure.
isometrics and all the lifting in the world, and I'm like, that's not going to get me back. My knees are probably going to feel okay, but I'm really going to be hesitant to get back to dunking. And there's something about jumping max effort where it's like I'll have banged up knees for like months, and then I'll be like, I'm gonna go do some really intense box jumps or really intense jumping, and if I do it right, or it's like the next day or the next few days, like I'll be feeling great in my patellar tendon, and it's like that's contrary to what everyone would be saying about like the slow heavy is the antidote to the
Mm,
fast stuff, and I'm like, there's something about doing the activity that maybe it like tunes up your whole nervous system to like activate everything
something.
properly, but then at the same time that's one case where I feel really good. I've probably had 10 or 100 other cases where it's like I've had the opposite, where I just blow things up and I'm much worse the next day from doing
Yeah.
the goal activity.
Yeah.
So yeah, too complex to know, and
Hopefully we do. Hopefully we do know
yeah,
soon. Like
yeah.
hopefully we can. I mean, this is like Keith's work, isn't it? Like, could we simply, I don't like to use the term, but could we reverse those changes to a healthy tendon? And it would be amazing. It really would be.
You know
But
what?
obviously it's a
I
lot of
think
theory.
that it does it happen. You see it in horses, like race horses, all the time.
Yeah.
They get ruptures and
Yeah.
then they naturally heal over time. I think the problem with humans is we just don't have the patience. Like, how many studies
Yeah.
are you seeing where like we did a really thorough scan of the tendon, which probably the UTC would be the best because there's much less operator error than there is with like an ultrasound. And then an
Yeah.
MRI doesn't give you the best view either, but it's like do it and then do it 5 years later. And let's see what the tendon looks like after good loading and good metabolic health. Because, well, not 5, but maybe like 2 years, maybe 1 year, 2 years.
Yeah.
But a lot of the studies are like after a few weeks or a few months, they're looking at the changes in structure. And I think Peter said this many times too. Is like he just thinks that we're not giving it enough time to change the structure of the tendon, because
Do you
those
think
things.
six months is long enough?
I don't know. I think it depends on it. Just there's too many things that it would depend on. So like there is, yeah. Some of the UTC people, they'll scan like every maybe 6 weeks, maybe 2 months, and you can see pretty significant changes in that time if you get on a
Yeah.
good loading program that's pretty intense. But uh, yeah, I don't know. I don't know the answer. But I think the negative changes can happen very quickly, but I think the positive changes,
Mm.
yeah, they can happen in weeks, but I'm like, I bet you for the vast majority of people, like 6 months, 12 months, 18 months, 2 years, that's probably where it'd be like, if they get everything under control, you can probably take a really pathological tendon and turn that around. But I think some of the tears, some of the partial tears, they don't heal. I think they
Yeah.
just stay and they're just, I don't know. They
Chronic.
don't have the
Yeah.
stimulus to get to heal. They need an actual surgery to get that to happen. But, okay, this has gone on for much longer than I told you.
Yeah, well,
So let's,
yeah, I couldn't believe it. I was like, that was awesome. I'm looking at that going, when you said 2 hours, I'm like, we're almost at 2 hours
yeah.
30. That's funny.
Okay. Let's wrap it up because I think people hopefully they stayed for this long. But yeah, tell everyone where to find you, online, in person,
Uh,
whatever you got.
yeah. I wonder how many people stayed around to the end. Probably one person. Probably just my partner or my mum. So yeah, my socials is blake.sportspodiatrist. And exactly like yourself, Jack. I love socials and love bringing out information, and I love podcast formats are just awesome because you can have nuanced conversations, and it's a better way to get out the information. It's really hard to do via social. So I have a podcast called the Sports Medicine Project, where similar to yourself, we just get experts in the field on, and I'm a clinician, so I want to know clinical things. It's not always that tailored to the person in pain, but more so for clinicians, physios, personal trainers, doctors, orthopedic surgeons, that type of thing. And yeah, otherwise I'm doing my PhD, so follow along as and I asked you that question about 6 months because hopefully in a couple of years, I must do if you have me back on, we don't flunk too much with this episode. I'm hoping to try and see some of these changes within the tissue over 6 months. So we'll see how we go with some tendon protocols. So stay tuned for hopefully some cool research, which I know a lot of other people are doing. So it'll be awesome to see what's happening in 2 years with tendons.
Oh yeah, the guy. So Jared Amflick, he's in London. I've did 2 podcasts with him. I went to see him last summer, and he'll scan.
Oh, cool.
So with the NBA, he scans a lot of NBA teams, and I think he scans every 6 weeks, and you can see pretty significant changes in 6 weeks with following a loading program. So yeah, your thing was
Has he associated that with less risk? Has he associated that with them, like to show anything that like that's associated with any benefit, like other than just the structure, which we
Yeah,
assume is?
probably maybe not published, like hard to publish
Yeah,
something like that, but yeah,
for
definitely
sure.
that. I mean, there's this whole idea in the tendon world that many people have agreed on that the healthy tendon won't rupture. So I just think if your tendon is like 50% unhealthy, you probably have quite a bit of risk. If it's like 10% unhealthy, I would just assume you have much less risk. And then if it's
For sure.
100% healthy, like your risk of rupture is probably very low, although people will say, "Oh, I have scanned them and I've seen a rupture with a healthy tendon." But I always think like, I mean, you scanned it how, you know? And
Mm.
are you sure
Yeah,
you got the full
exactly.
view of that thing? Yeah, yeah. Anyways, we'll wrap it up. Thanks
Very
for
good.
coming on, man.
All right. No worries, mate. Catch you later.